And I said, I am on my way to read to kindergartners in your school district. Does that help? And he said, no, it does not help because you ran 2 red lights. I'm like, I did? So I set 3 alarms last night. I set one at 3 a.m., 5 a.m., and 6 a.m. So if I look tired, that's why. But I would rather be tired in here than well-rested and at my hotel. So I called this presentation, The World of Epilepsy is Waiting for You. And in my mind, it was like the world of epilepsy is waiting for you to be a difference maker in this world of epilepsy. But then I thought, no, for some of you, the world of epilepsy is waiting for you. And maybe you didn't want to be part of that world, but here it is. But I'm here to encourage you that both sides, whether the world of epilepsy is waiting for you or the world of epilepsy is waiting for you, both are full of hope and possibility. This is when the world of epilepsy became part of my story. This is me at 9. I was already feeling awkward, friends. I had those teeth that were so crooked, and my dad said, we can't afford braces for you. So, okay, you just live with it. I actually tried to create my own retainer with a paper clip. Anybody else? Oh my gosh, yes. And I would put it in my mouth and my gums would bleed, and I was like, I don't think this is a solution. And my mom cut my bangs with pinking shears. Unless you think it was just this year, no. Every year, starting in kindergarten, which was really bad, and she got a little straighter by 4th grade. But what was with the sailor theme in my life? I mean, seriously, 1st grade, I've got the whole scarf thing on, and then 4th grade, I've now, got the little symbol, anchor symbol. But, oh, do I remember this little girl. I remember her like yesterday. She felt awkward in her body. She was embarrassed of her teeth and her bangs. She loved taking piano lessons over there with her stuffed dog. It's an interesting looking stuffed animal there. Her parents were very religious, and we were going to pray about everything, and we were going to say the rosary after dinner every night. And I liked to twirl baton, and I was a brownie, and I was ready to fly up to being a Girl Scout. But then on January 25th, 1975, my world completely changed. And I had my first, what they were calling back then, grand mal seizure. I was standing in my dad's bedroom in our little house in Greendale, Wisconsin, which is a suburb of Milwaukee, and I was asking him if I could borrow his camera. I wanted to take pictures of the day. I didn't have anything else to do. And all of a sudden, I felt this weird, inexplicable pinch in my left finger. And I thought something had bit me. And I look at my finger, and it's now throbbing. And I'm watching my hand start curling into a claw. And I look at my dad, and he looks at me, and he said, "What's the matter, honey?" And I said, I don't know. My hand is numb. And the numbness proceeded to travel through my body. And I ran down the hallway to the kitchen where I collapsed on our gold linoleum floor into a full body seizure. And my mom kneeled at my side and started saying the Hail Mary. And when I came to, I didn't know which day it was. I didn't know where I was. And they rushed me to the emergency room. And the doctor told me I had a budding virus. And in that day, I became a different person. I went from the baton twirl loving little Girl Scout brownie who loved her piano to a terrified shell of a little girl. I was afraid to be in my body. I was afraid to be in my life. I didn't want to go to school anymore. I really just wanted to disappear. And so my mother, I have to interject here, we are all born into a story, as was I. I was born into a story with a mother who had her own trauma. 10 years before I was born, she went through depression in the Air Force, and they put her through 3 weeks of electroshock therapy. which back in the 50s, there was no muscle relaxers. They just strapped you up to electricity and zapped your body with seizures, essentially, to oust the depression. And my mom emerged from that, a shell of herself. So when I came along and started having these full body seizures, it reminded her too much of her own experience. And by God, she wasn't going to let me have medical intervention because she was very anti-medical now. So she took me around to various doctors who told me, you have a conversion disorder. It's your psychological problem that is causing this physical reaction. You are stressed. Then we went to a chiropractor who told me I was out of alignment. I had a pinched nerve in shoulder, and that was causing my spasms. She took me to a homeopathist that said, you have cerebral allergies that are affecting your entire system, and drink these potions, and that will oust the allergies from your body. And meanwhile, I grew more and more and more fearful and traumatized and hid myself. I was in 4th and 5th grade, and if I would feel my hand go numb, I would run to a bathroom stall and hide to have a seizure by myself. Or I would look for an open classroom door and lock it behind me and have a seizure by myself. Because if no one was going to tell me what was wrong with me, how would I tell anybody other than I have this thing that happens that's my fault and my psychological problems are making this happen, but I don't even know what they are. All I know is that they're doing this. That is wacky. I came close to diagnosing myself in 7th grade. There was a boy named Ray Clark in my class, and Ray had epilepsy. And we all knew it because Ray's mom came to our classroom, and she told us, if you have Ray in your classroom and this happens to him, this is what you do. You move things out of the way. You get him a cushion for his head. And I remember sitting there thinking, how does Ray feel about his mom telling everybody about his problem? She said, you may notice Ron staring off into space. This will be your clue that a seizure is starting. Well, I didn't want to notice that. Well, one afternoon at 3 o'clock, I looked at Ray to my right, the clock inching toward 3 p.m., and when everyone started stuffing papers into his backpack, Ray was staring at the chalkboard. Ray! It's time to go. But Ray kept staring. Ray, I tap urgently. Uh-oh. Within minutes, Ray toppled to his left, bringing his chair and desk with him and toward me. I jump up and everything, including him, crashes to the floor, his body flopping, his papers flying everywhere. I stand in shock, my eyes unblinking, mouth open, but for a different reason than the others. I am Ray, and Ray is me. My body does exactly what his body is doing. I have epilepsy. I felt giddy. I felt giddy with the excitement of learning the secret that had eluded me for years. I ran home from school so fast, I was breathless coming into the door. Mom, I have epilepsy, and it's Jacksonian epilepsy, and it starts in one part of my body, and then it generalizes, and they call it a seizure, not a spasm. I am breathless, waiting for Mom to catch my enthusiasm. I don't think so, Marianne, she says. It's your diet, and we're working on that. My diet? And we'll keep praying for a miracle. Ray Clark is my miracle. As real as any, but Mom isn't seeing it. A gift from one awkward kid to another. It's as if Ray had picked me to have a seizure next to in a moment of solidarity. Here, I imagine him saying, I'm going to help you out. But I don't have a Mrs. Clark in my corner, and nothing changes for me, and Mom and I never mention the word epilepsy again. That's trauma. I didn't have the words for that when I was a kid. I didn't know that this was trauma. It was physical trauma and it was emotional trauma. I went back to grad school a couple of years ago for a master's degree in clinical mental health counseling so I could understand how our brains and bodies hold our stories. And I learned from many wiser people than me a very simple definition of trauma that put a light bulb on for me. Trauma is overwhelming helplessness. It is overwhelming helplessness, and everything about my constant seizures was overwhelming helplessness. When the people in charge of me didn't do anything to help me or come alongside me to help me understand and own what was going on for me. Peter Levine, a very well-known psychologist, said, "It is not just the events themselves, but how they are internalized that define trauma. It resides within our internal landscape, shaped by the emotional and psychological imprints that we carry, that I still carry. I am so good at hypervigilance. I am slow to trust. I wonder if you're telling me the truth." Those are the psychological imprints from 9-year-old me. Diving into a little mental health education for a second, we all have a window of tolerance. Some people call it the river of tolerance, when our nervous system feels calm and connected. Trauma puts us out of our window, either into hyperarousal, where we are anxious and panicky and short of breath, hypervigilant, looking over our shoulder, or we go into hypoarousal, where we are numb, can't get out of bed, depressed. And for years, I fluctuated between both. I was never in that window and was looking over my shoulder for when the next spasm was going to happen. I was anxious, difficulty trusting others. I had so much shame, depression. I was tired, fight or flight, hypervigilance. This is what trauma looks like. And I don't think we realize that things like epilepsy have a very physical component and a huge mental health component that I lived, and perhaps many of you are living too. And how we mitigate that trauma is with a caring adult, a caring doctor, a loving presence, a foundation like what you're a part of today. I didn't have that. I didn't have that caring presence. I was divided from that care and belonging. 15 years later, I had a massive seizure in my dorm room at college. Actually, I think it was more like 9. And because I hadn't told anybody, my roommate, when she saw me sprawled out on the floor, was freaking out, called 911. And I was like, "No, just don't call anyone. It'll be over, I promise." I still didn't want anyone to know. I woke up from my seizure with every girl in my dorm floor looking down at me. I had bitten through my lip. I had peed through my pajamas. I wanted to sink into the floor of my college dorm floor. I was shepherded off to the hospital in front of all the college kids with their backpacks going to school, and it was the first time a doctor said to me, "You have epilepsy. Why aren't you medicated?" Yeah, it's a really good question. That's a really good question. And I got medication that day, and I was happy. I had a name, and I had help. And it was the first time, because I was now 18 years old, that I could start taking charge of myself and my story and help myself if the people who I had looked to for that help couldn't do it. I stayed on that medication for a long time. I was taking 5 pills a day of Dilantin, I think it was. No, Tegretol. It's Tegretol. I went off to college. I went to Ohio State University, kept taking my 5 pills a day. My neurologist said, "Be mindful in your lifestyle," as I'm drinking buckets of beer on High Street. I'm like, does this count? I didn't want to be different. So I thought, well, maybe beer and Tegretol is okay. And I never had a seizure in college after that big one, my first year. And I thought, okay, all right, maybe we're finally on smooth sailing here. And then I moved to Connecticut and got my first job in New York City. And I was at Jack LaLanne doing aerobics. Jack LaLanne, anyone? Anyone? Yeah, older crowd here? Remember like cardio? Like doing the windshield wiper move? And I was doing that on 42nd Street, and I felt the pinch in my left pinky. I thought, no, not here. Not in downtown Manhattan at Jack LaLanne. This would be a bad place. I don't know anybody here. So I ran to the bathroom. I started rubbing my hand vigorously. I think I believed I could rub it out. I could rub the seizure out. And by the grace of God, it stopped. It receded. But now I was panicked because I knew there was something still very wrong. So I went on a hunt to find help. I had an MRI. I learned there was something in my brain that shouldn't be there. They couldn't tell me what. They said it could be a tumor, it could be a blood vessel, it could be scar tissue. And so there I was, a 24-year-old young girl, taking the subway around the streets of Manhattan, interviewing doctors by myself. Tell me what you would do. I went to one guy at Columbia Presbyterian, a very big, important hospital with a very big, important doctor, and he said, we will operate off the CAT scan. And I said, my thing has never showed up on a CAT scan. Well, that's all right. We're going to make it show up. I said, I'll take my scans back, please. And then I went to Yale New Haven Hospital, and I met Dr. Dennis Spencer there. And I walked into his office, and he said, Marianne, if you were my daughter, this is what I would do. And for the first time, someone saw me for me, a terrified young girl in need of protection, guidance, and care. And I said, let's do it. So at the age of 24, I had brain surgery to remove what turned out to be a benign brain tumor that had been the cause of my seizures since I was 9 years old. He said, who knows why it came? Could be been there when I was born, who knows? But by age 9, it caused enough trouble up there to start my problems. Okay, take a breath, Marianne, because now I've lost my slides. Okay. There we go. Sorry for that. So during my recovery, I felt like I had learned the secret that I'd been trying to find out for 15 years. I felt affirmed. I felt like I knew for so long, and no one believed me. And so I felt light and safe. Finally, could I exist in my body? And so during my recovery, I like to say I was bored and bald. And really had about 3 months at home to recover, and I watched all the Oprah I could and watched soap operas, and I thought, all right, I need something else to do. So I went back to something I always loved to do, which was writing. It was a safe place for me. It was where my brain was doing something good. It was making up stories. And I wrote a very, very simple story called The Gift of an Angel. And it was a metaphor for how I believed God had finally put some earth angels in my life who could help me at the time I needed. And I decided I was going to self-publish this little book. And I took my writing and my very elementary drawings, yep, that's my art, to a printer, and I said, can you make this into a book? And they're like, sure. And I got 5,000 copies of that book delivered to my house, and I started selling them one by one. And my author career was born. I started receiving letters from people. Thank you for writing this. Oh, they started telling me about their babies that they had lost, and that their babies were their guardian angels. And I thought, oh my gosh, my words have a place with people. This is so rewarding to me. And so I started listening to life to see where other people needed words. And my very second book was called The Gift of a Memory. And it was inspired by a mom who lost her little boy at 2 years old. And she came to my house and she said, no one knows what to say to you when you're grieving, so they don't say anything. And I said, well, that's not okay. What do you want to hear? And she said, well, I want them to say his name, and I want them to bring up the memory of him, and I want them to help me feel hopeful that they will remember him. And so she took me to support groups for bereaved parents, and we sat in gymnasiums and quiet churches, and I listened to parents tell me what they would want to hear during their grief. And so I wrote The Gift of a Memory to be a witness to that journey. Some things seemed so usual on that remembered day. The sun arose, the birds awoke, and kids came out to play. For most of us, the hours passed much like the days before. We lost ourselves in busyness and rushed from task to chore. But it was not so for you, my friend, and forever will it be the day God said to your beloved, come home and dwell with me. May you sense your loved one's spirit on a lazy sunshine day and know the one you miss delights to watch you laugh and play. And may you hear your beloved's laughter in the misty falling rain and know the tears from heaven fall from eyes that share your pain. And may you feel your loved one's touch when mild breezes blow to caress your cheek and whisper soft, I still walk with you, you know. And there I had the bookends of life. And for 30 years, I've been filling it in for relationships and emotions of life, for bravery and parenthood and love. And in the beginning, I was writing to my own unmothered heart. I was writing words for parents that I had longed to hear growing up. And I didn't quite believe I deserved those words. These 3 books emerged as touchstones on my journey. Hooray for you, a celebration of individuality. For quite a long time, the world saved a place. Millions were born, yet none filled your space. Until the second of a minute of one special day, you took your first breath, and the world said, hooray. I love you so. I love you. How much? So much. How much is so? Way, way more than you know. I love you as bright as each sparkling star and as way out as space. I love you that far. And I read these words to my own children while my own unmothered heart said, am I that lovable too? I want to believe that, but I'm not sure I do. And finally, as I kept going through my own healing journey through therapy and friends and my husband and my family, I started to believe that I really was worthy of love and belonging, because my story and my mother planted an ache in my heart that transferred into a narrative of I am not lovable. And so as I healed, my books they moved from aspirational to embodied. And Be Brave, Little One is my mantra, and I want it to be yours. Be brave to believe in what you can't see, what these ups and downs all meant to be. Be brave to begin to listen inside to the voice of your heart, so truthful and wise. Be brave to step up and try something new. Be brave to step out when it isn't for you. Be brave to stand up and tell what you know. Be brave to sit down and say a hello. Be brave to go out and explore. Be brave to come home. You get to decide what brave looks like to you. And maybe some days brave is just waking up, hopefully on time. And maybe some days brave is just like, I'm done. I'm going home. Well, 35 years after my journey of surgery, I have written my own story in the form of a memoir called If You Were My Daughter, in honor of that doctor, Dr. Dennis Spencer at Yale New Haven Hospital, who was the first one who saw me, whose words changed me, changed my life in so many ways. And this is a picture of me and Bea at the Epilepsy Walk in Washington this year, where I got to read to some kids and meet these wonderful women, which was just another step on the journey to me standing here today. As I was looking for reviewers for this book, part of the publishing process, I reached out to a woman named Kelly McDaniel, who is a therapist and wrote the book Mother Hunger, which really spoke to me. And she said, Marianne, we heal by being witnessed. We heal by being witnessed. And that was another huge aha moment for me, that she so succinctly put into these words what I had longed for, what Dr. Spencer had given me, and what all my books do, hopefully for you, is they are witnesses to your journey. They are witnesses to your journey, where someone says, how did you know how I felt? And I said, because we all feel that way. And I want my stories to become a part of yours. So today I would like to share with you my newest children's book called The World is Awaiting You. The World is Awaiting You. The world of epilepsy is awaiting for you. Whether it's the world that you've entered that's waiting for you with caring arms, a world that is waiting to witness your story, or if you feel strong to be a witness for others and you're ready to use your hands and your heart and your voice and your courage to come alongside others, the world of epilepsy is waiting for you. The epilepsy world is big, as was shared. 1 in 26 people in their lifetime, the 4th most common neurological disorder. They look different for everyone. Different treatments are needed. So big. What is one thing one person can do? A lot. A lot. Because Angie standing before me, years ago, one person. And now I'm here, and you're here. And the hearts keep going. And you know what the best news is? You don't need to buy anything. You don't need to borrow anything to be a difference maker. You don't need to rent it, download it. You don't even have to ask AI. Like, you are so well equipped. Sitting in your seats, you have everything you need to be a difference maker today. Today, tomorrow, next month. Your face, your hands, your voice, your need to rest, your heart, your mind, your feet, courage, love, your spirit, those are your tools. Happy day. You're here at last, the start of something new. Say a hello, get ready to go, because the world of epilepsy is waiting for you. The world is awaiting your face, your eyes, your nose, and chin. Embrace your own hue, your style, your do. Welcome the self you're in. The world is awaiting your mind to roam and wish and know. Think your own thoughts, your whys, your why nots. Choose an idea to grow. The world is awaiting your hands to wave and make and mend. Discover a need, do a good deed. What kindness will you lend? The world is awaiting your feet on an epilepsy stroll or street. Go anywhere new, widen your view. What wonder will you meet? The world is awaiting your voice. To speak and dance and sing, cast your own vote, play your own note. What message will you bring? The world is awaiting each of your stories, the ones you get to plot and pen. The world is awaiting your courage to fuel your how and when. And if things get hard, because they do, and trouble shows its face, the world is awaiting your stop and rest. Give yourself some space. The world is awaiting your heart to keep and share and tend, feel and guide and tend, offer compassion, be thoughtful in action. Who will you befriend? The world is awaiting your spirit to shine and hum and thrive. Follow your fun on your journey begun. What makes you come alive? The world is awaiting your love. To keep, love yourself, to hold and share, be who you are, lead, help others go far, lead and listen with care. Now, today, is your bright beginning to feel and think and do. Make your own mark. Believe in your spark. The world of epilepsy is waiting for you. If you want to believe that one person can make a difference, I will end with a story for you. There's me after my brain surgery in 1990. Just last week, I got to present, or about 2 weeks ago, I got to present my memoir to Dr. Dennis Spencer. Yes. I had to do it by Zoom because he's in Connecticut and I was in Nashville, and his health is, he's having some challenges now, so he's actually a patient. And it was a beautiful moment. I got to read him a letter about how his words changed my life. I had pre-sent my memoir to his colleague who handed it to him as I was reading my letter over Zoom. And he wrote me back a letter. And the subject was you. And he wrote, "What an amazing moment last Wednesday. I had no warning of what was to happen, and the timing is also surreal." He talks about he'd been doing research and really missing the patient interaction. And now he's dealing with his own health issues. He has Hodgkin's lymphoma and is in chemotherapy. And he said the culmination of this is causing him to question his legacy. Imagine. And he said, then suddenly you reminded me of the importance of one person trying to make a difference for just one other person. Warmly, Dennis. What is one thing you can do? Let's close by reading this all together. Now is your bright beginning to think and feel and do. Make your own mark, believe in your spark, and I'm going to have you change you to me in the end. And I want to hear a really loud, the world is awaiting me. Let's hear it. The world is awaiting me. The world of epilepsy is truly awaiting you. Thank you. Oh my God. That's so nice. Ooh.
Look, the world has been waiting for you.
Thank you so much.
And for all of
Thank you.
Amazing. Well, I'm going to use this microphone and have you stand right here
Oh,
because we are
okay.
so very appreciative, right? I know that touched our hearts so deeply.
Thank you.
And we have been waiting for you, and we are so glad you are here. We have this little token for you and are so proud and honored to know you and have you here. And so one more round of applause, please. And of course, I want you to know what she said is true. You don't have to buy anything or download anything or AI anything to belong, but you do have the glorious opportunity to purchase Marianne's books throughout this day, but especially during lunch. So she will also be able to sign those books. Thank you so much, Marianne. Amazing. Amazing. So I would like to invite you to turn to your neighbor and say, I am glad that you're here on both sides. I would like you to turn to your neighbor and say, the world of epilepsy has been waiting for you. And thank goodness we are all here. Wonderful. Okay. Well, we are so glad that you are here. We have been waiting for you. And just so you know, we look forward to this conference every single year, and we have been anticipating your arrival. So literally to have you here is a joy. And also in this work that we do together, in this belonging we continue to build. So if I have not had the pleasure of meeting you personally, my name is Renee Roederer. I'm the Senior Director of Programs and Community Care for the Epilepsy Foundation of Michigan. And so I also have this great pleasure of introducing our speakers for our next session. So I'm so glad that they will be joining us up here in a moment. This general session is sponsored by Henry Ford Health, and it's such an important topic, epilepsy and brain health, supporting cognitive function and well-being. So I get to introduce our wonderful folks. Dr. Vipa Wasadi is an adult epileptologist at Henry Ford Comprehensive Epilepsy Center, and Dr. Jules Constantino, known by many of our teens in the room as Dr. C, is a pediatric epileptologist at Henry Ford Comprehensive Epilepsy Center. So we're going to hear their presentations in just a moment and then conclude with 10 minutes for your questions. So I want you to be thinking about those questions throughout. So in just a moment, we're going to be inviting them to the stage. I think they'll be coming in, and that's wonderful. Okay. Take a moment and chat with your neighbors for just a second, because I think they're outside dealing with something, and we will be right back. You are. Okay. I'm so sorry. I thought you were outside. Okay. I didn't see your face. Okay. Okay, so I will invite you to take your seats again with this wonderful community we are so honored to be a part of. Okay. And as we settle, please help me welcome to the stage Dr. Vipa Wasadi and Dr. Jules Constantino. Let's give it up. Okay. I thought we were going to. We have a clicker, but I thought we were going to have a computer up here, and I'm a little confused, so just a moment. I know we're a little early, but I saw you both here, so I went ahead and started.
Sure. No, then we get the computer.
I'm going to ask about that. Alex, they're supposed to have a computer. What's the problem? Do you know where that is? Okay, but they need to be able to see it, unfortunately. So, okay.
We'll grab mine to get it uploaded. Can you give me like 2 minutes really quick?
Okay, all right. Okay, we're going to deal with one technical thing, and then we will be right back. So please make yourselves at home. Sorry about that. I'm so glad that you're here. Thank you so much. Okay. I'm going to step off and then come back on and get it all going in again. going to bring it up, and I'm going to announce you one more time.
Sure. No, I'm just thinking.
Yeah. And we were ahead of schedule anyway, so we're okay.
Yeah, people get to relax a little bit.
Amazing. Okay, great.
How are you? So glad to see you. Oh my gosh, good. Thank you for being here today. I can't wait to learn from you, and I'm right up front. I'm gonna be soaking up every second. How are you doing today?
Good.
Doing good.
It's good to be around you today.
I know.
Yeah.
So many people.
Right.
I know.
Yeah.
And everybody's just excited to learn and be together, and
Right.
it's a good thing.
It's really great to identify how many are patients and how many are parents or their,
Yes, we do. I'm 99% sure when they do the registration, they ask like kind of
your
how you
patient,
identify your connection to epilepsy.
Right.
So I'm sure that they could get you that information.
Yeah.
Yeah. Usually it's pretty 50-50, at least during my time.
Because they need a driver, right?
Exactly. Well, yeah, we have a good population of people with adults with epilepsy, caregivers, and then a lot of parents too.
Right.
So,
Right.
kind of all. Yeah.
As we look at this.
Okay, so we have both of your PowerPoints pulled up on here.
Yeah.
So you can look at both of those. And then, are you still good using the clicker to show what's going to be shown on the screen? Okay.
So how do we do this? Like together, can this be connected to this?
So we actually have, maybe, possibly. Is it better that way to do it? Like we go get. Okay, we'll go grab the tech person. So like you want to control like.
Oh, were they planning to control the slides? Is that?
No. You can control them with that.
Okay.
But they're already built into like a separate presentation.
Okay.
We took your guys's and combined them so it was like in order. But I think we can switch it so that if you want to control it off here, you can. Yeah.
Okay. Or that's fine. We can just
Are you sure?
yeah.
So that is there for you to see, but every time you change it, it needs to happen up here, right?
Yeah.
Or like. And you're like, boom. Yeah. Coordination.
Yeah.
Is that okay?
I guess.
If not, we're gonna go grab the tech person.
No, that's
So,
fine. We can probably it's okay. We can just get it started. That's okay. No big
are
deal.
you sure?
Yeah.
Okay.
Okay, but definitely have that for your, so you know what's coming next. And oh, okay. Let's see.
Okay. Yeah. Yeah. I'll tell you what, we're just gonna give you the master computer, and then then you'll just be able to automatically like do it. Cool? Okay, that'll be easier.
Yep, it's gonna blink out the screen from there. Okay.
Thank you so much for your patience.
I'll call everybody back. Is that okay? Yeah.
Okay. All right, cool. Let's do that
So
then.
this is up here.
So I just have to click this red button.
Just the forward button. So on the right hand, this right arrow,
this one.
and it'll move it forward. And if you go too far, hit the left arrow, and it'll move it back. And
Okay.
Then, yeah, or this on that computer. And then just whenever you guys are ready, switch on your microphones. Okay.
Amazing. All right, I'm going to call everybody back, and then we'll be ready to go.
Oh, or you can stand up here.
I'll need this.
Stand up there too. That's usually
Don't start yet.
Okay. Thank you.
I think we could.
They might have it off up there because we're not like going.
Hello?
This one works.
Yeah.
Oh, perfect. So I don't need this if I'm controlling from here.
You can do both.
Either way. If you're more comfortable doing that, you can do that.
Yeah.
Give that right.
Okay.
Okay. Good.
Amazing. Let me get everybody back, and
Yes.
you're ready.
Good.
I'm gonna keep it.
All right, everybody, come on back to your seats. We are ready for our next session. Thank you for our patience as we figured out a little tech. How wonderful to have Dr. Wasadi and Dr. Constantino with us today. Could you please give them one more round of applause? And we are ready to start. Thank you.
Thank you, Renee. Thank you, everyone. It's so nice to see everyone this morning, and we are excited for the agenda ahead. and learn together. And thank you, Marianne. It was an amazing, inspiring talk this morning. So we all learned a lot. So today we are going to talk about epilepsy, something that is not as visible, that comes along with it. And those are cognitive concerns that some people may have. By the end of this session, we hope that you'll walk away with some of these 4 key points. Understand why cognition and well-being matter so much in epilepsy. Recognize how seizures and EEG changes and anti-seizure medications, they affect the cognition. Identify the lifestyles and treatment strategies that help support brain health. And know when to screen for conditions that could be of concern and refer or seek help for neuropsychological care. So when we talk about seizures, again, when we talk about epilepsy, it's more than seizures that we treat. And neurocognitive functions, when we say about brain health is more of functions that include memory, processing, attention, and language. So these functions help us in daily activities. What we do, how we feel, how we do our daily work at school or at our employment, and how does it affect in our relationships. And seizures itself can manifest with many different conditions along with some triggers that include infections or any metabolic imbalance or just neurological condition itself, and that affects our cognition. So we know that if there are recurrent seizures, then that declines the memory, that can decline memory or executive functions. And as compared to general population, we have seen that people with epilepsy suffer 8 times more. That's a lot than other brain disorders like dementia, depression, and anxiety. So let's take a moment to look at cognition across lifespan. In childhood, we'll learn more about it from Dr. Constantino. But this is the time when our brain develops and develops new connections, and there's a lot of learning of different skills, language functions that take place. And it's very vulnerable at that time when the seizures happen and disrupt the connectivity as well as the medications that can affect brain functions. And identifying that and applying strategies during those times does help. As we go on to adulthood, there are other things that happen. Attention, memory, executive functions get affected, and this all depends on different types of seizures and the treatment that are given at that time. And then as we proceed to elderly, more adult population, there is a different, another aspect that comes into picture, and that is aging. Some things that happen with aging that includes memory problems, dementia, other comorbidities, and all these does affect brain health with time. And identifying all these, it's very important to separate all these together to see what could be the primary cause of memory concern. So again, we know epilepsy, it comes along with other comorbidities. When we say comorbidities, these are other conditions than seizure itself. And along with that is the memory complaint that we know we just looked at, recall, processing, attention, language functions, and all these are affected. The effect is multifactorial. It depends on the seizure activity, the EEG type of activity. We see medications, sleep, and mood, and all these remain often under-recognized. So it's important to discuss with your care provider about how you feel, and because there are different categories of comorbidities that could be separated. There's physical comorbidity like sleep disorders that could play a part. Fatigue, migraines or headaches, the mental health illness like anxiety, depression, and cognitive impairments like, again, memory, attention, processing issues. So when we look at cognitive domains or neurocognitive domains or memory functions, in a neuropsychological test in those with epilepsy, there are 5 key elements that play a role, and that's for most of us. Executive functions, this is mostly the frontal lobe function that's responsible for planning, decision making, more of a flexibility, processing, attention. There's learning and memory, and this is more like how we take in the information, how we store the information. This is more about the recall, free recall or acute recall, how we have event recall, and then there is language function, how we process language is naming, finding words, having correct grammar, fluency, how we comprehend. The 4th part is social recognition. It's recognizing emotions of people or other person's perspective, what we call theory of mind, or our own insight, our own perspective about the condition and behavior. And then last but not the least are the perceptual motor functions, where we see how there is hand-eye coordination that affects in our day-to-day lives, visual perception and other motor coordination that we do little things like eating, cutting food, veggies, writing, driving. So these are 5 key important functions, just to lay a brief background on. So to begin with, we talk about seizures and seizure burden. So what is seizure burden? Seizure burden is the amount of seizure, the frequency of seizures, and the duration of seizures. The more they are, worse the cognitive outcomes, or more the effect on memory. And studies have shown that about 60 to 70% patients will have some amount of memory impairment in those who have recurrent seizures, and be that just language processing or little attention. Not all of them will display all, but some to some extent. And why does this happen then? This happens because there are structural changes, meaning there are conditions that the connections of the brain that get affected with time, and also the functional changes, meaning the connectivity. So the structural changes may be fine, the MRI may be fine, but the connectivity with timing and coordination of the brain activity, it gets affected, and affected by by epileptic seizures. So we can imagine it's so important to have these seizures under control that can lead to substantial improvement in cognitive functions. So we all know the test called EEG is the brainwave test, and even in a person who appears to be normal, in those who have epilepsy, in between seizures, the EEG could show some abnormal activity that could disrupt the neuronal networks. When that happens, people may have some amount of mostly attention problem or functioning problem, and it is also what we call task dependent. That is more obvious at that time. And studies have shown that the more abnormal activity we see on the EEG, we do see more of attention problems or memory problems in those patients. So it's not like one size fits all for memory symptoms. Different conditions, different epilepsies will have different memory symptoms. In those, here are just some example. We know there's frontal lobe, parietal lobe, temporal lobe, and occipital lobe, just broadly. In particular, temporal lobe, which is one of the most common type of focal epilepsy, the primary functions are short-term memory or recalling brief recent events. So that's more of an episodic memory that people may have deficits. When it comes to frontal lobe, again, it's a command center of the brain where executive functions, decision making are the primary functions where that could get affected, and people may see that more in impulse control and some paranoias. So every lobe will have their own primary functions. If that is involved during seizures, maybe the seizures are starting from those areas, or maybe they're spreading to those areas, but they may get affected. And then there are generalized epilepsy. We know they could, the discharges here could be all over both the sides, and typically there could be attention processing speed and learning difficulties. So identifying also the type of epilepsy, we can seek resources for memory symptoms accordingly. Now, epilepsy in older adults, I have to say, this is on rise, because epilepsy incidence itself is rising. More and more people have so it's not only the epilepsy or genetic or the primary epilepsies. With age, we see that people get diagnosed with strokes or head trauma or oftentimes brain tumor. And with that comes the irritability in the brain, and those do affect the incidence. So we see that, and here you can see that there are many risk factors that can affect an older population, be that diabetes, high blood pressure, cholesterol, heart problems, stroke. So there are a lot of vascular risk factors, along with the Alzheimer's, what mentions here, Alzheimer's pathology. It is a particular type of protein that gets deposited in the brain in situations of Alzheimer's dementia. So that we all know is common in the elderly, and so there's quite a few overlap in this group of patients who have epilepsy. So they may have many other risk factors. So this is very interesting and recent research. This is a prospective study of Framingham Heart Study. I think it's important to quote. This is a longitudinal follow-up. I think they started recruiting patients in 1948, and over decades. So next generation got recruited in the 1970s. So over decades, they followed up patients, and they have used the subcategories of patients in those who have dementia and those who have epilepsy. And they saw that over years and years that those who have dementia are twofold likely to develop epilepsy, and those who have epilepsy are also two times likely to develop dementia. So discussing any of these with your care provider is very important to see how we can seek help in getting that addressed as well. Then come the anti-seizure medications. We all know about this. So there are various factors that come into play when we talk about anti-seizure medications. Yes, they help reduce seizures, and because the seizures are reduced, memory symptoms get reduced. However, some of them do have side effects of memory that can affect memory. So a good balance of controlling seizures with the dose and managing adverse effect is important. Then why does this happen? Why do recurrent seizures cause this cognitive dysfunction? So with recurrent seizures, sometimes we also see what we call status epilepticus. Seizures are back to back. So that induces oxidative stress what it is, it's sort of like a rusting in the nerve cells, and with that also alters the growth factors in the brain. It's called brain-derived neurotropic factor, and it can cause neuronal death. And this is very common in hippocampal area, the temporal lobes that we know are the common short-term memory centers or language centers. So these areas are closely linked to cognitive dysfunction. So again, we end up blaming these to anti-seizure medications. Oftentimes, the memory functions when there are a few anti-seizure medications on board, but we also should understand that having them on board is equally important because it helps control seizures. Now, along with that, we know that there could be underlying disease that can also affect memory symptoms, and this includes, say, had there been a brain injury or any hypoxia, what we call low blood oxygenation, or any stroke or low blood flow to the brain, or some genetic disorders like Fragile X and Dravet syndrome, that themselves come with memory concern, with cognitive, developmental delay and cognitive delay, and that can affect cognitive functions in epilepsy. So it's very important to tease out the cause of cognitive dysfunction. Again, we know some of these, just laying it out there, sedation, slow processing, attention deficits. We have seen that with anti-seizure medications, in particular older ones. That's phenobarbital, benzodiazepines, topiramate, to note. It can cause language and word finding and attention complaints, but again, on a higher dose, and it's all so much case-by-case basis that not all patients will have these side effects. So we do have neuromedications that could have more favorable outcomes, so it's important to discuss with your care provider. So another thing to note is polytherapy. When we say polytherapy, that means we are talking about many more medications, more than one medication. Monotherapy is one medication. So with more medication, there is higher risk of cognitive and behavioral side effects. So the aim for the care provider and even the patients is always to have monotherapy. However, we have to start a second medication or third medication to have better control. And so there should be a rational reason to add on these medications. It should be noted that these medications should have a complementary mechanism, because these medications act on different receptors and neurotransmitters. And because they have different actions, it's better to target the control by different medications. And that will also help in minimizing the side effects. So again, this is what we have seen briefly. Cognitive impairment could be affected by anti-seizure medications, just polytherapy. It could be different types of medication. It could be dosages that could affect. Then there could be psychiatric comorbidities like attention and depression that could affect memory. Then seizure burden we talked about, increase in frequency and duration of seizures, and the underlying etiology that, there could be something underlying like trauma, neurodegenerative condition, and just the brain structure or function itself may be not in sync, or there may be something concerning that can cause cognitive impairment. So what can we do? To begin with, let's talk about anti-seizure medication dosing, timing, and reversibility. Yeah, cognitive side effects could be adjusted, could improve by reducing dose if seizures are better controlled, changing the formulation, or switching another anti-seizure medication, or evening dosing, because then the side effects may happen when person is asleep, and daytime they feel more clear. Or even when they get started, consider slow titration of these medications, because there is always something called adjustment-related side effects that with time, if it is slow, brain gets used to the medication, it's easy to tolerate these medications. And it's important to avoid the peak sedating periods when people are at work or school. That can help with memory functions. So I have to put this slide because, with medications, all side effects, and there is sometimes we cannot avoid but need to have some anti-seizure medications, multiple of them, polytherapy. Other than that, we know that there are other emerging treatments, like you may have heard VNS, vagus nerve stimulation, responsive nerve stimulation, that's RNS, and deep brain stimulation for epilepsy control, and that can reduce seizures. So by reducing seizures, we see that there is improvement in memory functions. And just to see if somebody is a candidate, you really have to talk with your care provider and undergo the testing to see that's a possibility. But again, with this, there is no side effect, as you would, systemic side effect, I should say, as you would with some other anti-seizure medications. So that's how it could help. Now, going on to lifestyle matters, some of these are basic, and we know, so sleep, nutrition, exercise, we all know, stress management, social engagement, substance use, they all influence cognition and seizure risk. But it's important to note that they're very low risk. It may be tough to implement them, but they are very low risk and high outcome that can help. Sleep, we all know, sleep deprivation lowers seizure threshold. Why? Because when there's sleep deprivation, or when there is light sleep and people don't go through deep stages of sleep, then the brain doesn't rest as well, and that can lower seizure threshold, that can worsen attention, memory, mood. Yesterday only I saw a patient and I learned something from them. I've been talking to them about this for the last 6 months. They said they're using this app or Mozart effect. It's what, 2 piano, D major. They're using this and they're putting that for an hour, and they fall asleep and they feel much more rested, they feel much more relaxed. There are no studies, but there are some anecdotal reports of that helping some people. And it's sort of like a non-invasive neuromodulation, I should say. It's just helping modulate the brain activity in becoming more synchronized for getting good sleep. Then we have to see if somebody is having waking up with significant memory concern, increased daytime sleepiness, then obstructive sleep apnea is something they should talk to their provider for, because with CPAP and all, we have seen improvement in seizures and memory function. So again, sleep hygiene, bedtime routine, and that needs to be followed. And if there are any concerns for nocturnal seizure, then that needs to be assessed. So this is a long list of anti-seizure medications. Most of us may know that may have sleep as a side effect during the day. So these could be adjusted at night to help with sleep, at the same time to decrease daytime sleepiness, if that is a side effect for them. Nutrition and brain health. Food is brain fuel. Balanced diet, we all know. Whole grains, proteins, fresh fruits and veggies, so important. It's easy to get distracted by seeing yummy food, but it's very important. Nutritional deficiencies, again, very important. B12 and vitamin D, folate, these are considered to be brain vitamins. So it's good to get them checked by your care provider, and there are strategies to replace or supplement them depending on the number of the blood test. We know there's ketogenic diet. Yes, that could help in seizures, in controlling seizures. However, that may have some metabolic consideration, and that can affect memory symptoms. So it's easy to implement ketogenic diet in little kids. It's very tough to implement with all the discipline that's needed in adults. But that is something that you need to work with your care provider. Exercise, important for all of us. Some of these are so basic, but what happens if we don't exercise? Yes, we all know. But with good exercise, there's increased blood flow to the body, to the brain, increases attention, executive function, mood. This is for regular people as well as it has shown. The studies, the randomized control studies have shown its effect in those with epilepsy. Aerobic exercise is very common. And obviously, all these need to be under the supervision of a care provider. No swimming without supervision. Another point to note is strength training, in particular women with epilepsy, because with strength training, like dumbbells or like the easiest thing that you can do is important for bone health, because we are more likely to have low bone mass, osteopenia, osteoporosis. So it's very important to remember, do this and implement in daily routine. And with this comes the neuroplasticity. Okay, just a few more slides. Mental, there's mental health, social engagement, cognition important, anxiety, depression, very common. We use psychological help, and social participation, cognitive stimulation is very important. Something to mention is these things also help support cognitive reserve. Now, what is cognitive reserve? This is a protective factor against future cognitive decline. So it's good to have all the social interaction and network, volunteer in activities, community activities. It's very important to do that. Last but not the least, substance abuse, substance use, recreational drug use. Sometimes we feel that some things are normal, but they do interact with anti-seizure medications, lower seizure threshold, worsen mood, sleep, and can worsen memory symptoms. So advise moderation. Now with times, we know there are a lot of tools and apps. So just a few things to note. There are some reminder apps, calendar cues that people can use. Again, these are emerging tools and just an adjunct to clinical care. Again, these are some strategies that people can use by using these apps, calendars on Google Calendar, Apple Calendar, maintain their seizure diary, logs, appointments. Just a few things to note on here: cognitive training and memory tools. I have personally tried this Lumosity app. It's amazing. I really enjoyed. This is for people who enjoy game-based training, but again, we know it's not a replacement meant for regular memory help. And also we have to make sure that people are aware of the consent, are aware of the data sharing, health-sensitive data sharing for this. There is Cognifit brain training app as well that could be used, but again, it should be a daily short habit. Shouldn't be too overwhelming, causing fatigue and worsening and triggering seizures, and people should have a realistic expectation for this. We know there is occupational and academic support for people with epilepsy. There could be accommodations, extra time, quiet workplace, break periods, and it's important to coordinate with our occupational therapy or school teams for this. So if there's one thing I want to stress on is resilience. And Marianne, thank you for your talk, and it was so heartwarming and inspiring that people could understand how people can make a U-turn in their life. So it's so important we have a routine to build resilience. Just helps us to bounce back and adapt and connect with the world back. So again, the goal, you work with your doctor to maintain a goal of good seizure control with medication, surgery, devices, and preserve cognitive health. quality of life and emotional well-being. And doctors may use your feedback to, and also EEG and neuropsych testing for the further management. For you, it's important to set short goals that are achievable, manage stress, use social support, peer support groups, epilepsy foundations, support groups, very, very powerful networks that you can use to cope up with this condition. So just to wrap up, when we talk about epilepsy, it's not just seizures. It's about nurturing our whole brain and whole self. So that's all I want to say. Every step you take towards brain health is a step towards greater independence and well-being. Thank you.
Well, thank you, Dr. Wasadi. That was wonderful. It's a hard act to follow. And it's always such a pleasure and an honor to be here. I want to say the loving arms of the Epilepsy Foundation, all our friends here, and the comfort and the family and village environment that you provide to help people with epilepsy. So thank you to the Epilepsy Foundation for all that they do. So I'm going to look at many of the same factors that Dr. Wasadi told us about, and I'm going to look at them as they pertain to children. So I think in our lives we all have these moments, these lightning-like moments, which change the way we think. And one of them was when I was in Australia. I was a young buck. I just finished my training in Australia. I'd come back home after my fellowship in Boston, and Peter Silberstein, who was old and doddery like I am now, and I was like, what's he going to teach me? And we were walking across the tunnel to get to the parking lot one day, and he said, you know, Jules, it's more than just the seizures. You know, it's the learning issues, the mood issues, the stigma of, and that's what it's not just medication and seizures. And he was so right, and that changed me forever, you know. So thinking about the burden of childhood epilepsy and thinking beyond the seizures, and we know that children with epilepsy struggle with issues of cognition, with mood, and the social consequences of epilepsy. So overall intellectual ability in children with epilepsy is comparable to those without epilepsy. But children with epilepsy are at greater risk for learning problems and academic underachievement. And as Dr. Wasadi told us, we struggle with deficits of attention, of memory, of executive functioning and language. And those are the main domains that we think about. Mood comorbidities are significantly more common in children with epilepsy, and we can think about depression, anxiety, ADHD, which is a little bit of a pet topic for me because I have a little bit of it, which wasn't recognized, and conduct disorders. So these are the things that we often think about. So there's a complex interaction between the epilepsy, the cognition, the psychological symptoms, medication, and things like seizure frequency, age at onset of the epilepsy. So epilepsy beginning at a young age is often associated with more cognitive comorbidities. Whether or not there's an underlying structural brain abnormality, the effects of anti-seizure medication, psychosocial stresses, those all go into the big potpourri which affect a particular child. So 50% of children with epilepsy have some form of learning difference, and I'm not going to call it a disorder or a disability, because if we anticipate it, we can intervene and we can help the children. But, you know, one of the things that I have to teach myself as well is a lot of times when we're approaching children, we focus on the negatives rather than the positives. And that's a difficult thing to do, but something that we should do all the time. So the differences can range from subtle differences to severe disability. And we know that about a quarter of children with epilepsy will have a cognitive impairment, which can vary from mild to severe. So epilepsy typically affects these domains: speech and language, attention, memory and executive functioning, and processing, which is really part of executive functioning. So that they're interrelated, they're integral to success in school and beyond. And early recognition of problems in any of these areas is critical so that parents and teachers can take the appropriate steps to help children achieve their learning goals. So what are the contributing factors? And Dr. Wasaidi told us about those which contribute to the cognitive challenges. Firstly is the seizure activity, right? Seizures disrupt normal brain function, the neural connection, and even the interictal, the IEDs, the epileptiform activity that doesn't quite mount up to a seizure that can affect our learning and condition. The underlying cause, so if there's a structural brain anomaly, if there's a genetic anomaly, we only got 15 minutes left. We only started 5 minutes ago. We've got 30 minutes. So, yeah. So the underlying causes, so add another 10 minutes. So the brain disorder or genetic disorder, medication side effects can contribute to learning issues, psychosocial factors, worry, anxiety, self-esteem, and then comorbid conditions. So children with epilepsy have a higher likelihood of ADHD, autistic spectrum disorder. So let's break down these cognitive challenges. We have challenges with attention and concentration. So ADHD, the children struggle with sustaining focus, they're distracted. Absence seizures can be mistaken for daydreaming, and vice versa. Daydreaming can be mistaken for absence seizures. Language and speech, and especially with left hemisphere seizure foci, the children may have trouble understanding language, expressing ideas, finding words. Executive functioning is and that's planning, persistence, organization, self-regulation, impulsivity, problem solving, and then processing information. So as children may need more time to process information, complex tasks. So when speech and language are impaired, there's learning and socialization are greatly impaired. And it seems like we have a time issue, so I may not go. So if there is a language disorder, you need to work around it, right? Kids will a hands-on approach, speak clearly, slowly, be specific, use your non-verbal communication, lots of visual cues, repeat and rephrase, engage the child in conversation, encourage learning new words. Read to the child every day. We spend too much time on these things. Use visual prompts and play word games. So these are things just to encourage building of language. So attention, ADHD is very common in children with epilepsy. 30–40% of children with epilepsy have an ADHD. Sometimes it's not always ADHD. Sometimes it's the more daydreamy, inattentive type of ADD that we call ADHD, predominantly inattentive. So in the classroom, we have trouble with distractibility, staying focused. We need redirection. But the main issue relates to executive functioning, starting something, staying with it, finishing it. We have lots of wonderful ideas, but how do I plan? How do I sequence? So we get sidetracked, we shift from activity to activity, and it takes us longer to finish. And organization, my child's lazy because he doesn't turn in his work or doesn't want to finish his work, and recognizing that ADD is very common. Some medications can increase attentional difficulties. Depakote is famous for that. And then the other thing, of course, is that there's this mythology, which is often even child psychiatrists, pediatricians have imagined that a medication for ADD will lower your seizure threshold. And now I've never seen that. It's very rare. So I think just because you have epilepsy, that's not a contraindication to trial of a stimulant medication if we think it's necessary. So what are the strategies? Sitting in front of the class, small group, breaks, extra time for tests and assignments, organizational aids for planners, especially for kids with milder ADD as they advance into high school and the school curriculum expands. What is executive function? And really that executive function is the set of mental skills that allows individuals to plan, organize, manage time, focus attention. So it's really our CEO, you know. How do we organize, achieve our goals, stop from going off on a tangent and finishing what we want to do. So the key components are working memory, cognitive flexibility, and inhibitory control. And the way I explain working memory to my families is, if I'm driving around the street and someone nicks in front of me, well, I know a bunch of words that my mother didn't teach me. You know, and I might say, well, you know, but what I say to myself is, you know, these people, I don't know who they are. I don't know where they're coming from. Maybe they have a gun. Maybe I should just ignore it. Maybe I should look just straight ahead. And that's hard to do, especially for kids with the more impulsive type of ADHD. Where's that situation coming from? What are my choices of action? And, you know, so we have to appreciate that. So children struggle with the impulse control, the persistence, the transitions part. That's also an important part of executive function. So executive function allows us to consider more than one option, choose one, and then create a plan of action based on past experience. It's critical to a child's ability to success and to use other intellectual abilities. And if epilepsy has compromised executive functioning, a child whose basic skills are intact may struggle in the classroom and in communication with each other. And again, the executive functioning difficulty becomes more pronounced as we get older. So how do we help? We structure, that's very important, set up routines. Habitual activities require less active processing, are less likely to be forgotten. Plan ahead, set small, achievable goals. I often say computers are wonderful for kids with executive functioning issues. They give you that external framework to maintain a task. Advanced warning and memory difficulties. Of course, 70% of children with epilepsy report memory difficulties. As Dr. Wasadi said, it's more common in kids with temporal lobe epilepsy. The executive functioning difficulty is more common in children with frontal lobe epilepsies. So it's a complex operation, and you know, is affected by other cognitive processes such as attention, effort, self-monitoring, speed of information processing. So children may lose memories before a seizure because the brain doesn't store them. After a seizure, confusion and fatigue can interfere with the formation of memories, and interictal discharges can disrupt formation and retrieval of memories. So make topics meaningful to the student, use different learning styles, teach information in small chunks, carry over themes of learning from one environment to the other. You know, what's going on at school, sort of recapitulated at home in therapy and speech, teach mnemonics, visual aids, and allow the student time to review. So what are our strategies? Educational supports are critical. You need an on-site school system and a village to help your child. So we want open communication between parents, teachers, and medical professionals. When do we think about neuropsychology evaluation? And we have wonderful neuropsychologists in our system, and we can do a formal evaluation to look at cognitive strengths, cognitive weaknesses. How do we tailor a support plan? You all know about IEP plans and 504 plans. According to, eligible children are legally entitled to special education services and classroom accommodations. And if you struggle getting those, the Epilepsy Foundation can help you. Classroom accommodations, again, sitting at the front of the class, breaks, extra time, resource help in areas of academic difficulty, for kids that struggle with that organization piece, an extra set of books, sending missed work home, being allowed to email your homework in instead of carrying it in your knapsack or bag. And it's a multidisciplinary approach. So we have neurologists, psychologists, speech and language therapists, social workers, educators, all are part of the village to help the child do his best, be his best. Home support, simplify in structure, use visual aids, short instructions, and a calm, low distractibility environment to help with focus. One-on-one support, especially for kids with executive functioning issues, to help starting, completing tasks, follow through. Teach your child organization strategies, a planner, provide modeling of organizational skills, maybe a little calendar chart on the fridge at home, and encourage brain-boosting activities. And that's not the iPad, that's things like puzzles and reading and playing outside, exercise to stimulate the brain and improve neuroplasticity. Learning does not stop at the end of the school day. Parents have a huge impact on child's development. It's helpful to meet with the teachers and the school staff regularly, and the parents can present medical information about their child to help educators better understand the child's needs. So that's looking at the cognitive issues, and we think, again, just the bullet points. Think about language, think about attention, think about executive function, think about memory. How can we help with those issues? I want to talk a little about stigma. And children with epilepsy are vulnerable to stigma. And I always ask the kids about this at Camp Discovery. And we have enacted stigma. That's what other people do to us because they perceive us as other or different. That can be things like exclusion, teasing, harassing, bullying. Your teacher not allowing you to participate in a group activity because you have epilepsy, or go on a field trip on the school bus. That's stigma, right? And then it's felt stigma, If I feel lonely or powerless or shame or less than, that's felt stigma. So there are social consequences: low self-esteem, confidence, difficulty making friends, social exclusion, difficulty with transitions, fears of disclosure. Going to a new school and telling people that I have epilepsy, that's a big thing, right? 40% of children with epilepsy develop anxiety compared to 9% of children without, so a lot more common. And it's anticipatory worry, maybe I'll have a seizure. Social phobia, fear of seizures in public, embarrassment. And 30% of children with epilepsy also have depression, which is under-recognized and undertreated. And it's harder to pick up mood disorders in young children because we don't have the words. So we're going to isolate, sick in our bedroom. We're going to have little hissy fits, meltdowns, acting out behaviors. And then these are just some of the symptoms of clingy, stomach aches, negative thoughts, unexplained crying, quick to upset or anger, panic attacks. So what strategies can we use to support mental health and emotional well-being in children with epilepsy, encourage open dialogue, create a safe environment where your child feels comfortable discussing fears and worries about epilepsy without judgment, you know. Be honest and age appropriate. So be honest, simple, age appropriate information about the condition. And understanding epilepsy helps reduce fears and misconceptions that the children might develop on their own. Acknowledge feelings, validate emotions. You look worried now, are you worried now? It's okay to feel sad, it's okay to feel anxious, it's, you know, and model healthy coping. Share your own feelings, how you manage stress, like going for a walk, listening to music, and then this teaches by example. Promote social activity, encourage participation in age-appropriate hobbies, social events like play dates or camp, and we have a wonderful camp for children with epilepsy, Camp Discovery at North Star Reach, and that's really a wonderful forum. It's a place where kids can meet other kids with epilepsy, learn about the epilepsy. We have an ask the doctor, ask the doctor session so they can ask questions, you know, they do lots of activities. They're not stigmatized, you know, I can't go swimming or, you know, rock climbing and all sorts. Well, we used to have rock climbing, not anymore, but maybe one day, I don't know. And again, focus on strengths. Nurture self-esteem by highlighting strengths and what they can do rather than focusing on limitations. Encourage responsibility and self-management. Involve children in their own epilepsy care. As we become teenagers, that's when a transition begins, right? And what type of epilepsy do we have? What type of seizures do we have? What medications do we take? What can we do to remember to take medication? And this builds a sense of control and competence. Routines that Dr. Wasadi told us about, balanced diet, regular sleep schedule, consistent daily routines, educate others so that other adults in their lives know what to do if a seizure occurs, and this allows for greater flexibility and independence. Connect with peers. We talked about support groups, camps, and you know, what I hear is that a lot of the kids at camp, once they leave camp, they form these little networks and they stay in touch with each other. So it's a lifelong social connection for them. Utilize your resources. You're not alone. We have the Epilepsy Foundation, you have your social workers, you have counselors, you have your neurologist. So yes, utilize us. Come to us with your concerns. Consider therapy, and I think especially for you know, kids with anxiety, depression, kids that are feeling different. You know, Andrea, I don't know if Andrea's here yet, the psychologist, you know, she's wonderful at, you know, getting into helping the kids. And then parents, don't forget yourselves, right? Self-care for mums and dads, because we don't want you to get caregiver burnout, because you know, you're no use to anybody if you're burnt out, right? So get that me time, it's important. And there's just a picture of the Epilepsy Foundation. That's at North Star Reach. There's Shannon right in the front. Okay. And that's all the kids. I think we're saying goodbye at the end of the camp. And this is the old camp in Kalamazoo. Bonding there, I think, something like that. And then that's the village. There's Kyle, Stephanie, Kim. So when do you seek professional help for mood disorders? Be alert for changes in behavior and mood. withdrawal for friends, wanting to be by myself, irritability, learning problems sometimes. We can't concentrate at school, negative state, oh, I don't want to be here, why, trouble sleeping, and seek professional help if symptoms are persistent or severe. So, as we said, comorbidities interfere with academic performance, social integration, emotional development, and supporting cognitive and learning, attentional and emotional differences is an essential component of care for the whole child. And our goal is to enable children with epilepsy to reach their best potential in terms of learning, socialization, communication, and enjoyment of life. And all these consequences of epilepsy play a major role in school success and determining long-term success educationally and occupationally and socially into adulthood. Yeah, so I think it's, mums and dads, you have a lot to think about, but I hope this helps.
Thank you so much. Thank you. Well, that was absolutely wonderful. And a few affirmations. I just want to thank you. It's so clear. You are both wonderful doctors, but also wonderful teachers. So let's give them another round of applause. Yeah. Wonderful. And also, it's very clear you care so much about the whole person and the whole community, and that really means a lot to us. It is time for your questions, which is really exciting, and we'll take 10 minutes for those, and then we'll have a 10-minute break. So what we are going to do is, if you have a question, you can raise your hand. Someone will come to you with a microphone, and we're going to wait to make sure we have the microphone so we can hear everybody, and we can also hear online. But please try to keep your question brief so we can get to as many as possible. Who has that first question? Okay. Great, right up here. And you can also say your first name if you'd like. It'd be great. Okay.
So my name is Natalie, and I had a question about the memory part for epilepsy because I have a hard time with my memory. So my seizures are controlled, but could you still have memory issues even if they are controlled, or no?
You can use these mics too. Well, let me turn it on. Testing my ability to turn things on. Okay, there we go. Or you could pass it back and forth too if you want to use that. Okay, sure.
Yeah, well, I'm sorry to hear this. It also depends on the number of medications and what medications you're using right now. So you may want to discuss with your doctor if also we need to correlate, are your memory functions starting when your seizure started, and are they worsening since then? It's great that the seizures are under control, but medications could play a part in it. However, you may want to check with your doctor, and they may want to send you for neuropsychological testing.
All right, thank you.
Thank you so much. Thank you. Okay, our next question. Great.
I was curious. I've had epilepsy for 62 years. How many times throughout life in that time has the type of seizure been changed?
Like the terminology? Yeah.
Terminology.
Changes in terminology for seizure types. Like how often has that happened maybe over the years?
Yeah, so I think the first terminology came in 1970s. Then it was just grand mal, petit mal. Then 1980s, early 1990s, we have those complex partial seizures, focal seizures. And last 10 years, they have changed over to what we are calling focal seizures. So it's just a play of words. I tell my patients it all depends on what the EEG shows and what you experience. It's just for doctors to understand the terminology.
Good. Great, thank you. Okay, another question.
I can
please.
perhaps have a more cynical view of why the names keep changing. And you have a lot of people on committees who've got nothing else to do. But what should we call complex partial seizures? Maybe we should call them focal.
Yeah.
Most recent is the proposal to change that focal seizure with impaired awareness to focal seizure with impaired consciousness. So again, it's play of words.
Changing, wonderful. Okay, another question, please. Yes, Sandy.
Hello, my name is Sandy. Our daughter is currently on several seizure medications. Her seizures have been controlled for 7 years, but now as a young adult, she is struggling with anxiety, depression, and some of her doctors are suggesting that she go on antidepressant medications. Could it be the medication she's currently on that need to be adjusted as opposed to throwing more medications at her to now deal with this side effect?
Yeah, that's always, many issues can contribute to mood disorders. How old's your daughter, did you say? 26. So I think, there's many issues that could contribute to that. I think a lot of the young adults that I see with epilepsy, I mean, they might say, well, my life is so different, so part of that could be social factors. Part of it could be, there's an organic component, is the way the brain, the brain manifests anxiety and mood disorders. So it's not necessarily situational, but it's medications can contribute to anxiety and depression. So lots of different things. Have you tried therapy, cognitive behavioral therapy? You've tried that. So you want to make sure you have a therapist that understands epilepsy as well, because sometimes you'll see a therapist, you've got nothing to worry about. Sure. But, and I think maybe we have some connections. And it could be medications. How many meds is she on? 3. So that's always hard, because what I sometimes say, the most difficult decisions people make are starting seizure medication and then stopping seizure medication. That's always a tough decision, because you can never promise that you're going to stay seizure-free. So maybe sometimes the medications can contribute to depression, and there's some medications which are more likely to do that. So think about which medications would it be worth trying to take away one of those medications, understanding that there might be a risk of seizures. And then, medications often do help people. So I think there's not an absolute no to ever thinking about medication, but you want to do your due diligence, and I think counseling and looking at the seizure meds, and then, could there be an option for medication?
Thank you. I would also just like to share that we, the Epilepsy Foundation of Michigan, have trained therapists about epilepsy and functional seizures and associated mental health conditions. And on our website, if you search, you can find it on our website, but you can also just search for Therapy, Epilepsy Foundation of Michigan. You will see a list of those therapists who are available to you. We have time for 1 and maybe 2 questions, but definitely 1. So we'll go over here. Thank you.
Hi, my name is Suzanne, and I was wondering about the memory. I had an experience where sepsis went throughout my whole body, and I was in a coma for 3 to 4 weeks. I don't remember my wedding. I don't remember my kids' teenage years. My short-term memory is shot. Is there ever a chance where you can get some memories back? I'm on medication for memory also, but is there ever a chance where those memories would come back, or are they just lost?
How long ago was that?
I got sepsis in 2023.
Recently, okay. Yeah, well, yeah, I'm sorry that happened. So we end up seeing this type of these type of symptoms, but with good. Have you been to neuropsychological evaluation again? I'm saying because it is so important to understand. Yes. Yeah. So there are chances that it may not be. There is so much neuroplasticity in the brain. So with all that lifestyle, good sleep and following up with a therapist who can also help in cognitive behavior therapy is something probably that would help in this condition. But the more we keep on using our brain, better it is for the brain to be active in this condition. So medications do play a part, but they are needed in this case. So it may be challenging to adjust those.
Yeah, thank you. In a moment, we are about to take a break, but I want you to know that in the back part of the room, we have a table for Henry Ford Comprehensive Epilepsy Center. I know you have your passports today, so if you have a question, you can still go and ask, but please join me in saying thank you to our physicians. Thank you. Wonderful. So now we have 10 minutes. We do have restrooms through this door, a small restroom right across the way. You can also turn left and find those there. Enjoy coffee and one another. We'll be back at 11 o'clock. That was awesome. Thank you. You're great. What was that?
You. I'm gonna come up and work.
I know. I feel for her so much. It's been really hard. You all are extraordinary. That was really, really a great way to kick that off. So, thank you. Yeah.
Oh my goodness.
So special.
Thank you for taking the time, and thank you for your patience with the time. And we always love, of course, the camp shout out.
Thank you. Thank you so much for helping with this.
Yeah, and I'm so sorry because that makes perfect sense. Thank you guys so much for being flexible. That was really
This was perfect actually.
Oh,
I think
good.
you should keep it this way.
Yeah.
Because standing by the side it's too hard to look at this light. This
Yeah.
way you feel everything under control. You have
You're
this.
there, ready to go.
Yeah.
Thank you so much for your patience as we got that all worked out.
Yeah.
I think you can keep it like that for the rest of the day. It's very convenient.
Good.
Yeah.
Okay, good to know.
Amazing.
Thank you guys so much.
Cool. Extraordinary. And I love the photos that Shannon picked out for you.
Welcome back, everybody. Welcome back. I invite you to take your seats. Thank you. Welcome back.
I'm just going to sneak in here real quick.
Please.
And switch this over.
Should I get going while folks are taking their seats?
You can, if it seems natural. Yeah.
I'll do it. Okay. Welcome back. Thank you so much. Well, good morning. Good morning. What a great morning it's been so far. It's been informative, it's been inspiring, it's been enriching, it's been connecting, and it's not even noon yet, so it's been quite a morning. My name is Yaniv Ribon. I am honored to serve on the board of directors for the Epilepsy Foundation of Michigan, where I'm privileged to wear a number of hats and contribute in many ways, but more than anything, I am just proud to be a member of our community. The community that together we have built and we cultivate together in our great state of Michigan. And if you are here from outside of Michigan or online from outside of Michigan, welcome. We are elated to have you. I am grateful to share that this next session is sponsored by C.S. Mott Children's Hospital, part of the University of Michigan Health System, otherwise known as Michigan Medicine. And so in this session, Dr. Chloe Hill, adult epileptologist at Michigan Medicine, and Dr. Carrie Neville, who is a pediatric epileptologist at C.S. Mott Children's Hospital, will talk with us about treatment options for drug-resistant epilepsy. They will talk with us for about 50 minutes, and then I'm going to come back up and facilitate some live question and answer. And so I hope you take some time to think through some questions and conjure the courage to ask them. So we'll do it that way. With that, Dr. Hill, Dr. Neville, come on up.
Hi, everyone. I'm Chloe. I've never been to this conference before, and I have to say it's incredibly moving to experience this community. Thank you so much for inviting me to talk today. I'm thrilled to be here, and I'm particularly excited to talk to you about this topic with my awesome colleague, Carrie Neville. So we'll get started. This is a big topic. We'll do it the best we can do with it, and we look forward to questions at the end. All right, so this is basically what we're going to talk through. We're going to talk a little bit about what drug-resistant epilepsy is, how we think about it as clinicians, and then go through options of treatment. So I'm going to go through a very academic definition of epilepsy. Obviously, if I asked you what epilepsy is, you would give me a more colorful, real-life definition, but I think it's important to level set about what epilepsy is academically, and then what drug-resistant epilepsy is. So the way we think about this is basically reaching a threshold where someone's had enough seizures or enough reason to have risk of more seizures that they need an anti-seizure medication or treatment. And that's how we ground this definition of epilepsy sort of quickly. We might say at least 2 unprovoked seizures, but there's a couple other elements that we consider, does someone need treatment? And about 1% to 2% of the United States population has epilepsy. How well do our anti-seizure medications work? Well, fortunately, they work pretty well overall. So this is showing data from 2 studies, one in 2000, which was kind of a landmark study in our field that helped us define how to think about response to therapy, and then a more recent one. And these show similar things. About half of people with seizures achieve seizure freedom with the first medication, so that's pretty good odds. Another significant portion achieve seizure freedom with their second medication, and then subsequently to that, you can add additional medications that may help you. In general, about 2/3 of patients or people with epilepsy have achieved seizure freedom, so that's a fairly good amount. But there's also people who can't achieve seizure freedom with medications alone, and that's what we're going to talk about today. One thing I just want to take a moment on this slide is, although there's bigger numbers with the first and second medication, every time we try new medication, there is a chance that it's going to be the one that's going to make the difference. So as we talk about these other ways to treat seizures in addition to medications, they're not instead of medications. We think about these things in parallel. But what I want to draw your attention to is the chance of achieving seizure freedom with these medications drops significantly, and that's why we consider other ways of treating seizures, which may have slightly more risk or be slightly more invasive, and we're going to talk about those now. So drug-resistant epilepsy, we talked about epilepsy, that's showing that you can have, that you've had multiple seizures or you are at risk of having more seizures. Drug-resistant epilepsy is defined by whether or not seizures were controlled with medication. And so typically we use a threshold of failure of adequate trials of 2 tolerated, appropriately chosen and used anti-epileptic drugs. So that means it was the right drug for those type of seizures. It was a real trial. All the things that you might think didn't work to get seizure freedom or seizure control. And so that reaches the threshold of drug-resistant epilepsy. And now we're going to talk about the other options in addition to medication, which we still consider in parallel to treat drug-resistant epilepsy. I want to set up the context a little bit, which I really don't have to tell the people in this room, but I'm going to do it anyways to build into the rest of this discussion. So the burden of uncontrolled seizures is substantial. There's a lot of evidence that I can quote to you, and people in this room may have lived experience about it decreasing quality of life. It increases, uncontrolled seizures increase disability and unemployment. There's real consequential driving restrictions and transportation issues. There are associated psychiatric comorbidities such as depression and anxiety. Social stigma is still, unfortunately, a much bigger problem than it should be. And there's an elevated risk of death, to be really frank about this, which I think is important when we consider risk-benefit calculations. There is an elevated risk of death with uncontrolled seizures, and we talk about sudden unexplained death in epilepsy often in this context. It can reach up to 1% in annual risk. And there's other accidental injuries and deaths that are associated with this. So this is a real burden, and we weigh this against what can be done. So this is leading me into the case for epilepsy surgery. Epilepsy surgery is not new. It's been done for over 100 years. We've learned a lot along the way. It's done better than it was in 1886, fortunately. But I want to talk to you a little bit about what we know about epilepsy surgery. So one of the really important studies looking at this, one of our highest levels of evidence, which is a randomized controlled trial, was performed in 2001. So we're well into this body of evidence about how effective and how safe it is. This was a study of people with temporal lobe epilepsy, which is the most common type of focal epilepsy in adults. As a side note, we have certain seizures that target focal epilepsy, we have certain procedures that target focal epilepsy. We have certain procedures that target generalized epilepsy. So all seizure types should be included in this discussion, but what I'm talking about right now in this trial is a focal epilepsy. Comparing patients who underwent surgery versus medicines alone at 1-year follow-up. And, the point of this, what this study demonstrated is that seizure freedom was much greater in the surgical group, close to 60% versus the medical-only group, close to 10%. And quality of life was also improved in the surgical group, and complications were not that common. And the one death was actually in the medical arm. This shows the same data visually, if you're a visual person, which I am. On the left, you have the medical group. The blue bars are no seizures, and on the right, you have the surgical group. The blue bars are no seizures, and you can see this dramatic difference with epilepsy surgery. And this really established how effective and how safe this procedure can be. This is another chart to show you, we've studied this now over time. Obviously 2001 was a long time ago. This is actually still another old article, but I like this table. We continue to study it, there's more recent evidence. But this one describes also how it can be helpful with seizures in different locations, and the likelihood of seizure freedom can differ by where your seizures are coming from. It's also hugely individualized, but I wanted to show you that we use it across different types of epilepsies as well. Okay, so the seizure outcomes after surgery, and then we'll get into the procedure, but I just kind of want to tell you about why we might do these procedures. The most important one probably is to treat seizures, and we care a lot about achieving seizure freedom. This is a common way that we score seizure outcomes after epilepsy surgery, the Engel Epilepsy Surgery Outcome Scale. Ideally, people will be in class 1, free of disabling seizures, but but you can also hugely improve quality of life and safety and the other things that I talked about just by improving disabling seizures. So we have a classification scheme for all of these goals. There are also many important non-seizure outcomes after surgery. Survival has been shown to be improved with a lower death rate of close to 9 of 1,000 person years in the surgical group versus the medical group in this study. Quality of life is improved. Employment depends on which study you see. Driving is improved. And I want to make a point that in the short term, we don't rapidly taper medications, but in the long run, that's also a possible outcome of achieving seizure control. With surgery, you may be able to get off many, if not all, medications. Cognitive outcomes are improved. There was a fantastic session just before this on cognitive outcomes, so I won't spend a long time on it, but we do also see improved outcomes of some types of cognition after surgery, particularly compared to non-surgery, which can not achieving the seizure control that can come with surgery and having ongoing seizures that can harm cognition. Complications of surgery. Now, this is brain surgery, so I don't want to undersell that it's an invasive procedure, although we have levels of invasiveness. But the major medical complications and major neurological complications are relatively low for a major brain surgery. So because of all this evidence, about 20 years ago, there was a strong recommendation that there's benefit of, this was specific to that older evidence about temporal lobe resection, but there's evidence that surgery is beneficial as compared to medication. And I'm quoting now, for patients who are compromised with such seizures, referral to an epilepsy surgery center should be strongly considered. Okay, so now we're going to dive into how we know what type of surgery and if surgery is right for someone. So I want to preface this, which I think is obvious, but I want to say it out loud. All of this is extremely individualized to a person, as it should be. It's an operation on a person's brain, but I'm going to give you the overarching ideas of how we think about this and how we assess for brain surgery. So there's 2 critical pieces to assessing if surgery is right for someone. I think if people get to the point of where surgery could be right, it definitely makes sense to look into it, understanding that you'll gain more data and figure out if it's right for you or not. You don't have to know at the start if it's right for you. The point is to go through the exploration and figure out if it's right for you. Okay, so we need to know where the seizures are coming from, obviously. And the second is we need to know if that is a part of the brain that can be removed to treat seizures safely. So there's a very famous epilepsy surgery really gone wrong from 75 years ago, from the 1950s, before we know what we know today. A famous patient called HM who had bilateral surgeries on the parts of his brain critical to memory. His seizures were somewhat improved, but he could not form new long-term memories, which was devastating. Not an acceptable outcome to anyone. So as we're assessing, do we know with great certainty where the seizures are coming from, we're also assessing, do we know with great certainty that that's a piece of the brain that's safe to operate on? And that's why it's quite involved to understand if someone would be a good candidate for surgery and what surgery that should be. So this looks complicated. It can be complicated. It's highly individualized. And the only reason I show this is because it's a very careful and individualized process. This is not something that's jumped into, but we also really know very well how to assess this. And there's a lot of support along the way to get through this process for people for whom it makes sense. Okay, so we obviously need to see seizures. We use electrical data, electrical assessment to figure out where the seizures are coming from. Obviously, a seizure is abnormal electricity of the brain. We have to capture and understand that electricity. This is showing, for people who get excited about EEG, a left temporal seizure. We have to understand the structure of the brain. We want to understand, is there something unique to a certain part of the brain that makes it capable of generating seizures? We put all this information together. This is showing, I don't know if I have a pointer. Oh yeah, okay. This is showing a part of the brain. Maybe it stands out to you in the left temporal region that looks a little bit bright. Maybe there's a scar there, and that can hint to us there's something abnormal about that part of the brain. We do neuropsychological testing. This is a functional assessment of how the brain thinks. So if you're particularly good at language function, it's less likely that your seizures are coming from that part of your brain that processes language, because that part's working very well. If you struggle more with math, it might be a hint that seizures are coming from that part of your brain because that part of your brain's not working so well. We put all this information together. It goes on, but I'm going to keep going. So we test people's speech, how well they do with word recognition and speech skills. We do other ways to study the structure of the brain. So we have several clever ways to understand this. I showed you an MRI, which is an image of the structure. We look at how the brain metabolizes energy, because that can hint that one part of the brain is metabolizing energy differently, and that might be where your seizures are coming from. We do a SPECT scan, which injects a radio tracer at the onset of a seizure that can highlight where that seizure starts. And there's other ways to study the electrical assessment. We might do magnetoencephalography, which is using magnets to assess the electrical dipole within the brain. This is a very cool study that takes a while to explain. I'll try to do it really briefly. We'll do a WADA study to see if we removed a certain part of the brain from one side, can people still function? Does their memory still work? And we can actually do a experiment, like sham version of that, by putting half the brain to sleep and seeing if people can still function normally. And we will do that to collect that safety data to make sure that the seizure surgery that we're planning would be well tolerated. This is a very cool test called a WADA. And then if we need further information, often we'll plan a surgery where, in addition to the first electrical data that I showed you, which is from electrodes on the head, we may put electrodes in the brain to find with absolute certainty where the seizures are coming from and to test that it's a safe place to operate on. And then sometimes we'll actually try to record information about how the brain functions by giving electrical stimulation inside the brain. So very thorough, really multifaceted assessment to get to the bottom of this. So we have all this information. We went through all the stuff. I didn't even talk about semiology. Obviously, we care what the seizure looks like. That helps us tell where the seizures are coming from. And then we put all this data together and we think, what is the best surgery for a person? To date, our best seizure freedom outcomes are with surgeries where we can remove that tiny piece of tissue where the seizure is starting. We call those resective surgeries. If we know exactly where the seizures are coming from, they're coming from one part of the brain, and we know with great confidence that it's safe to remove that one little part of the brain, we prefer that because the seizure outcomes are better. We call that resective surgery. However, often that's not a good option. The seizures are coming from multiple parts of the brain. The seizures are coming from all over the brain in a generalized epilepsy, or we know where the seizures are coming from, but it's not safe to resect that part of the brain, to cut out that part of the brain because that's critical to language. Then we have a lot of other ways to treat seizures through neuromodulation, which is this amazing field that's blown up in the last decade that Carrie's gonna tell us about. So we have lots of options. It's not like you get to the end of this and you're out of options, and that's the beauty of all the advancements that have been made in our fields. So to very quickly go through these resective options, and then I'll turn it over to Carrie. So a very common surgery that is performed for temporal lobe epilepsy, in fact, the one that I introduced the topic with in that randomized controlled trial from 2001, is an anterior temporal lobectomy, where the front part of that temporal lobe is removed. Sometimes we can be even more precise with how much tissue is removed in a surgery. We don't have to get such a broad area because of where the seizures are coming from. And then a small part of that, instead of, this whole tip of the temporal lobe, a small part of tissue can be removed. This is called a selective amygdalo-hippocampectomy. Sometimes it's not in the temporal lobe, often it's not in the temporal lobe, but there's a part of the brain that looks abnormal to us, either electrically or structurally, and we can just remove that part of abnormal tissue. That's called a focal resection. Sometimes, for a variety of reasons, a person may not be a good candidate for a large craniotomy where part of the skull is opened. It's a big surgery. And we can offer another type of treatment, which is a laser ablation. We can zap it with a laser. And it's basically a catheter that inserts to the brain without a large craniotomy and causes a little bit of the tissue to be ablated or zapped in layman's terms that can treat seizures. Oops, sorry. Sometimes it's a large part of the brain that needs to be removed to treat seizures, and it can be a rather large surgery called a hemispherectomy. There's also a procedure called a corpus callosotomy, which we don't as frequently use in adults. Can I ask you to give us a minute on this? Or you can come up. So Carrie's going to talk to you about this because it's more commonly used in peds.
So I think one of the things that the goal of our talk today was to briefly touch on the wide range of options, and knowing all the options to treat epilepsy can be empowering. And so we focus so far on a resective option, but there are so many options for all different types of epilepsies. So corpus callosotomy is classically using a disconnection surgery. So the corpus callosum are the white matter tracts, the kind of superhighway of the brain that connects the two hemispheres. And for a certain type of seizure called an atonic seizure, it can be particularly helpful to disconnect that track. Because an atonic seizure is a sudden drop seizure. And it's that really quick propagation to the motor centers of the brain that can cause that drop seizure. And if you interrupt that pathway with a corpus callosotomy, disconnecting those fibers, you can stop those drop seizures is one of the main goals of this surgery. And so one of the shifts in epilepsy surgery has been not using only seizure freedom as a marker of success or improvement, but quality of life as well. And if you can control even specifically a sudden drop atonic seizure, but the person might have other seizure types, that can be huge in terms of mobility, functional status, and quality of life. And we'll go on to talk about other options as well.
That was perfect. Thank you, Carrie. Okay, actually, I got lost in my slides. That's the end of my part. The rest is going to be Carrie.
So we are both very excited about this topic, and we both, I think, tend to talk fast because we are very excited, and we had a lot of information to cover. This is another kind of switch in how we are thinking about epilepsy and epilepsy surgery. So one is the outcome of surgery doesn't necessarily have to be complete seizure freedom, though that's always the first hypothesis that we're working towards when we meet a patient. And then two, we were talking at our table a little bit about, the why someone has epilepsy and how that why can still be so elusive for so many people. But I think of neuromodulation as a little bit of a paradigm shift into the what. What is the seizure? What is that person's epilepsy? And that's something we're understanding a little bit better. And if we think about seizures and epilepsy as more of a network problem, when you don't have a single structural problem like Dr. Hill was going through, but rather a broader network. What are ways we can target and modulate then that network to be able to improve seizures and improve quality of life, even if a single resective focus or a single curative option seems less likely? And so we have more options than ever before, which is exciting, but we still have so much to learn. And so right now, as of now, there are 3 different neuromodulation devices that we can consider for a person who has refractory epilepsy, who medications alone maybe helped but were not sufficient, who maybe went through the epilepsy surgery evaluation or we knew early on maybe would not be a good candidate for a resective surgery. But even at the end of that long pathway, or even if we know early on it might not be the right option, we have other tools and other treatment options. So the 3 devices or neuromodulation options are vagus nerve stimulator, VNS, DBS, deep brain stimulation, or RNS, responsive stimulation. And this picture was already shown today. It's a nice way to look at those 3 devices and where they're placed, and we'll go into each one in more detail. How they work are very similar in a lot of ways, but there are a lot of nuances and differences too. And so again, the idea is that we are modulating a network. And so what we mean by that is the brain is composed of billions of neurons, right? Those are the cells of the brain, or the neurons. And in seizures and in epilepsy, a portion of these neurons are acting in an electrical way that's different. And if we can, even just from a region of the brain, figure out why the network is acting differently and modulate that network, that can be really helpful. And so that's the general approach of all 3 of these neuromodulation devices. Where you're modulating that network depends on which device you're talking about. So this was, I thought, just a nice picture showing that you're working on different areas of the brain for each of these devices. I also liked this picture. I hadn't really conceptualized it quite this way until I saw it. So looking at the baseline, someone who has risk for seizures, that risk changes maybe throughout the days or months or years. And we think of the seizure threshold. If you stack up enough risks, enough factors, your threshold of having a seizure gets lower, your probability of having a seizure gets higher. You might have your breakthrough seizures. And then you go through periods where things are relatively quiet, and then your threshold gets passed and you are at more risk of having more seizures. Responsive nerve stimulation, the idea behind it is that you're spending more time in the lower risk area, the lower probability of having a seizure. So it recognizes and responds to that individual's seizure network, and with the long-term goal of spending more time in the lower probability zone than the higher probability zone of having a seizure. Continuous stimulation are what the DBS and VNS are doing. It's giving continuous stimulation, traditionally at least. And the idea there is that you still have these fluctuations, but you shifted the whole curve down into the lower likelihood area of seizures. So you're reducing someone's seizure burden, you're making seizures less likely, and hopefully improving quality of life, even if it doesn't mean complete seizure freedom. So a little bit more about each device and what they look like. The vagus nerve stimulator we have the most experience with. A lot of people in the room might have heard of this device or be familiar with this device. This is where the device is actually placed, the generator, the battery, if you will, in the chest wall, and then the leads are up, tunneled into the vagus nerve in the neck. And so it's actually done by a neurosurgeon. It is an epilepsy surgery, but it's not a brain surgery in the traditional sense. It's all outside the brain. So it's modulating the vagus nerve, and going back, we do think that that modulates networks and deeper structures of the brain. It's the green areas highlighted here in this picture. There is a magnet that comes with this that the patient themselves has, that they can swipe the device to intervene on a seizure when it happens, give an extra stimulation, extra dose at the onset of a seizure, which can sometimes be helpful. And then these are the tools that the provider would have to help program the device and set exactly what those stimulation treatments are. So that's the wand that gets held over the device and then downloads information onto the tablet where we can actually see and then program new settings. So I guess I should have had a disclosure slide. I have no disclosures, no financial implications for any of these devices. I'm trying to present an unbiased view of all three devices, though I am a pediatric neurologist, so I have used these devices off-label as well. But to go over the approved indications for each device, the vagus nerve stimulator is approved for children and adults 4 years of age and older, so it's the only device that is FDA approved in the pediatric population. Again, it's the one we have the most experience with. It was approved back in 1997, and we think of it as a good treatment for both focal and generalized epilepsies that are not amenable to other surgery, like a resective surgery. Practical considerations is that battery life. So the battery life for a VNS lasts between 4 and 8 years. It's a pretty wide range because it depends on how often the device is going off and how much battery that utilizes. So the stimulation, so we're talking about delivering extra current or extra electrical activity into an abnormal electrical network is the idea, again, behind all these devices. How the VNS does that is it's usually set, or is set, for continuous on for 30 seconds, off for 5 minutes is the kind of starting parameter or dose, if you will, and then that can be changed and modified over time. So that's the duty cycle. How much of the day are you seeing that stimulation? So 30 seconds of stimulation, off for 5 minutes, and so that's how much time during the day or the duty cycle that you are seeing that therapy, that treatment. There are some, the newer model of a VNS stimulator can detect heart rate with the idea that heart rate increases and increases quickly at the start of a seizure. And so it can give an extra dose of stimulation when it detects that heart rate change, with the idea that kind of indirectly responding to potentially a seizure or that abnormal electrical activity by giving an extra dose of this current into that network. And then the patient has the power to swipe their own magnet too. If they see a seizure coming on, or a provider or someone, care provider sees a seizure coming on, they can swipe the magnet as well, which can be powerful. When we talk about, the efficacy of these devices, we heard about the efficacy of medications and surgical options. I use kind of a very broad approach to describing the efficacy of these, and say up to 2/3 of people get a 50% or more reduction in their seizures. And in the literature, it depends, on what group of patients you're talking about, what time point you're talking about, how long after surgery or the device placement are you talking about. So it really ranges, but I think that's a fair kind of broad, up to 2/3 of people get a 50% or more reduction in their seizure burden. And we'll see that's roughly true for all these devices, like I said, with some variability. It is still surgery, even though it's not brain surgery. The complications for all these devices, whenever you're talking about an external medical device, would include infection and a bleeding risk. Though again, since it's all outside the brain, then some of those risks are lower. You have a bleed, at the incision site, it's much different than having a bleed in the brain. Some of the unique potential side effects for VNS is because you're stimulating that nerve. So other things that nerve does is some of the kind of laryngeal muscles and vocal cords, and so you might have some hoarseness or a cough. Usually those things improve over time, and you can kind of adjust settings, kind of like going up slowly on a medication to avoid side effects. There are ways we can mitigate that. It can worsen sleep apnea, but it's not a reason not to consider the device, because you can just change the parameters of the device or more thoroughly treat the underlying sleep apnea, and it could still be an option. Advantages of this device in particular is we have the most long-term data for it, the most experience with it. It is, formally approved all the way down to 4 years of age. There are some evidence that it can indirectly improve other aspects of epilepsy. We heard epilepsy is not just seizures, right? But it could help with mood, cognition, and quality of life from that standpoint as well. And anecdotally, people reporting that it can help with their level of alertness and perhaps shorten the post-ictal state. So again, even if you're not achieving complete seizure freedom, can be a great option. The other advantage is you don't need to know where the seizures are coming from for this. You're stimulating the nerve in the neck. So you might not need to go through as much testing to get to the point of trying to utilize this tool to manage your epilepsy, but you don't want to miss an opportunity for a curative option either, which is why we have that really long pathway that Dr. Hill showed as well. The next device is deep brain stimulation. So this is very similar. The generator is placed in the chest wall, very similar to the VNS, but the leads are fed under the skin, behind the ear, and then into a deep structure of the brain. It's called deep brain stimulation. So that deep structure is the thalamus, and it's usually placed bilaterally, so on either side here. This is what you as the patient might go home with this programmer, and then the tablet that the provider uses in clinic to program the device as well. So where in the brain are we talking about? It's the structure here called the thalamus, and then even more specifically within the thalamus, it's a collection of cells here in the midbrain. It's primary or it's FDA-approved indication specifically for the anterior nucleus of the thalamus. So it's one very specific area in the front of the thalamus. It's approved for adults 18 years old and up. It's more recent, approved in 2018, though it's been used in the neurology sphere for a while for movement disorders like Parkinson's disease, a similar approach or device in the thalamus, but this is a specific indication for epilepsy. It is approved for focal epilepsy, thinking about this ANT location, but again, there have been off-label uses and other uses for this device as well. Similar battery life to the VNS, 4 to 7 years, but there's a rechargeable option as well, where you can recharge the battery externally rather than having to go replace a battery once it reaches end of life. So this is going back to this slide here. So far we talked about VNS and DBS is giving continuous stimulation, and the goal is to shift that probability curve down. So they're acting very similar in that way. It's constantly cycling on or off, giving stimulation for 1 minute, off for 5 minutes. Again, this is the kind of traditional use of DBS. There's been other uses over time as well as we learn more about using it for epilepsy. We talked a little bit about where it's located. So the landmark trial that looked at the efficacy of DBS or deep brain stimulation in epilepsy was called the Sante trial. And so here I liked this picture. It's 81 patients. So each bar represents a patient, and then it graphs that particular person's seizures after device placement. And so a few people did have more seizures, but you can see the vast majority of people had some improvement in their seizures. And if you take that, what is it, like the 40th patient, and draw a line right down the middle and say, what did most people experience? Well, the median, the middle, is that they had a 56% seizure reduction after device placement. With any of these, you have to think about at what time point you're measuring the seizure burden. So to break it down in a little bit more detail, 16% of participants had greater than 90% seizure reduction, so if you were kind of maybe super responders in some ways. 13% had a period of seizure freedom. 7.3% had a prolonged period of seizure freedom, but that kind of tapered off after several years. So looking at the 7-year mark, the follow-up study 7 years later, longer-term follow-up for people who've had this device placed, the median total seizure reduction at 7 years was 75%. This can have a side effect of stimulating the ANT specifically. For some people, can actually have a side effect of mood symptoms. So that is perhaps similar to what we talked about with some of the anti-seizure medications and something to be aware of. Risk is higher in those who already had some underlying mood disorder and mood symptoms, but it is a possibility. But overall, it was a very safe procedure even at the 7-year follow-up. We do use DBS in the pediatric population, and there is some literature to support it, though it is off-label use. So this was a systematic review of 21 papers that included 40 pediatric patients who had the DBS placed. Again, the ANT, the anterior part of that nucleus that we talked about, that deep brain structure, was the initial kind of primary indication. But in pediatrics, we target a slightly different area of that thalamus, sometimes to try to modulate a different network. And so we think that this CM nucleus perhaps has a broader network that could potentially help with more generalized epilepsies. So that's the idea behind targeting different areas and using the DBS in different clinical situations. Then the third device we wanted to talk about is the responsive nerve stimulation. Again, a lot of similarities with all three of these devices, modulating a network. The first two devices we talked about are doing it all the time in this continuous cycling fashion. You don't necessarily need to know exactly where someone's seizures are coming from, though for the ANT-DBS, it's usually targeting temporal lobe epilepsies. But you kind of have this predetermined location of where you're putting the device, either the vagus nerve or the deep brain thalamus structures. It's constantly cycling on and off in the background to modulate those networks. The RNS is a little bit different. It's responsive, is in the name, so it's responding to that individual's seizures. So this is the generator is placed actually right into the skull. So a piece of the skull is removed and a tray kind of takes that place, and then the generator sits flush with the skull. And then the leads are put into the area of the brain we think the seizures are coming from. So this is often something that becomes an option where perhaps you've gone through that whole epilepsy surgery evaluation, you're trying to localize someone's seizures. It turns out you can't remove that tissue, but now you know where the seizures are coming from with some degree of certainty, and it's coming from 1 or 2 locations, ideally for this device, and then you can more specifically modulate that specific network for that patient and target that patient's epilepsy. So then this is what the actual kind of monitoring device looks like, where the other piece of this is that there is some work on the patient's part, some homework, where it works best if you're constantly uploading the information that the RNS is providing about that person's seizures and epilepsy. So it's actually recording. These electrodes here have tiny little kind of EEG electrodes on them, and they're recording electrical activity in the brain and storing it temporarily in this device, and then you can upload that information, and then your provider can have access to the information that the device is recording. So this is also approved for adults 18 years and up, though again, we have used it off-label in pediatric population. It kind of is newer as well, but a little bit more recently approved than the DBS. It was approved in 2013. And again, the indication is really for primarily for focal epilepsies, if you can define 1 or 2 spots the seizure is coming from, because you have up to 2 leads that you could place into those networks and modulate those networks. So again, as we're learning more, we are using it kind of off-label in other capacities and treatment options as well. The main advantage is that information that you're getting. So it's actually recording off of those leads, and then you can look at the data, especially once you tell the device and you tell us when your seizure happens. And then we can look at the EEG information that's collected at that time and know what the seizure looks like from those leads at that time. And then you teach the device to respond at that time. So that's the responsive part. And so that's a different kind of strategy than the other two devices that we talked about. So it's giving a stimulation only when you tell it to or program it to. The idea is that it's responding to seizures, but in reality it's responding to any abnormal discharges that look reminiscent of a seizure. So it often goes off hundreds of times a day. That person's not having hundreds of seizures a day, but it's recognizing some abnormal blips and patterns that you told it to recognize, and then it delivers a stimulation. And so since it's only delivering stimulation when you tell it to, it's not on for 1 minute, off for 5 minutes all the time. It's only delivering a quick stimulation over a few seconds when it recognizes that pattern. That's in part why the battery life lasts longer, up to 10 to 11 years, because it's just working in a very different way and stimulating in a very different manner. But the idea is the same for all of them, to modulate that network and change the abnormal electrical activity and quiet it down to reduce the probability of seizures. This is what it looks like. So from those 2 electrodes placed in a specific area of the brain, we're actually recording EEG data from those electrodes that we can see on our computer. Once you download the data, we can go to the cloud and take a look at it. And so it's recognizing these spiky looking waves here, because we told it to. We said that could be the start of someone's seizures. And so it recognizes that and delivers a therapy, a treatment. And then the efficacy in general is fairly similar across the devices if you're using very broad strokes. And so at 1 year, 44% median seizure reduction. 2 years, 53% median seizure reduction, and at 9 years, 75% median seizure reduction. And I kind of saved this idea for the end on purpose, but I think because it's a different strategy and it's a different tool, the other kind of unique thing about it is that you're not doing a surgery, coming out of the surgery seizure-free, and seeing how long that seizure freedom can last for, and hopefully it's forever, but for some people, seizures eventually come back. This is a totally different paradigm shift, is you play the device, and then you don't even turn it on. So you leave the OR, and we haven't actually done anything to treat your epilepsy or your seizures. But the cool thing is that it improves over time. And none of our other therapies do that, right? It's not like the medications improve over time, like once you reach the optimal dose for you. The surgery doesn't necessarily improve over time, but these devices can modulate this network over time. And so if you're patient, the long-term benefits can be extremely helpful, but it's a long road to get there. And especially with RNS too, because you're actually learning from each visit about that person's specific epilepsy, that person's specific network, responding to it, and then waiting a few months to see how much did that improve. And then you make another adjustment, and then you wait a few months, and then you see these trends over time that with having the stimulation going on in the background, even stimulating out here in the vagus nerve and just having going on and off in the background kind of all the time, that you can have this cumulative benefit over years. So I think I covered most of that. For, I guess, unique side effects of this, just to kind of touch on each device, it really depends on where you're placing the stimulation for this one, so it's a little trickier. So you have the risk of infection, risk of bleeding, device management, but the actual potential side effects of the stimulation depends on what you're stimulating. So if you're stimulating the motor area of the brain and you turn that stimulation up too high, well, you might get some extra twitches, and we know we need to turn it back down. But we can assess that in real time and control for that. Similarly, like some tingling or paresthesias, if you turn the stimulation up too high too quickly and to get some tingling, then you can turn it back down. So some of it depends on where you're actually implanting the leads. There is kind of looking to next steps in the realm of neuromodulation. We kind of touched on this a little bit already, and that there's some evidence and some experience to suggest that we might be able to modulate even broader, bigger networks to target more generalized epilepsies. Then maybe we can even target more than 2 specific foci, maybe up to 3 or 4 specific foci for somebody. studying other areas of that thalamus that I talked about, but that's really a relay center of the brain for a lot of these networks. And so if the idea is to interrupt a network as part of someone's seizures, that can be an area to look at more and more. This got cut off. But the point of this was just to show that when you talk about efficacy, again, it depends on what study you're looking at, what patient population you're talking about. So in general, I feel like efficacy can be fairly similar, but there are some ranges reported. And then practical considerations, as you're considering, is the device right for me and which device might be right for me? Sometimes it's just thinking about where is the device going to be placed? What's the recovery going to look like? How often do I have to change the battery? With the RNS, I'm supposed to be uploading the data every day, and just some practical considerations. I do want to briefly touch on dietary therapies. It's another huge topic, but ketogenic diet in particular has been used for epilepsy for a long time. But we have other therapies as well that are kind of versions of that, modified Atkins, modified keto, low glycemic index treatments have been used, or MCT diets have been trialed. So it's a very, very high fat and even low protein, which I think is something I didn't fully appreciate when I first started, and a very low sugar diet. And so why don't we do this for everybody? Because that's not actually good nutrition, right? Especially for growing kids. And so it has to be done very, very carefully, very, very thoughtfully. And the idea of using diet to control a chronic condition like epilepsy is so appealing. Like using food as medicine is so appealing. But it's actually very not normal what we're doing to the brain with the ketogenic diet. The way it works is by inverting the metabolism of the brain. And so I think it's a wonderful option and a wonderful tool, and I've seen it help a lot of people, and it's definitely something that needs to be part of the discussion when someone has medically refractory epilepsy. But it has to be also used thoughtfully, and there are side effects as well. So here's what I mean when I say a high-fat, lower protein, and very low sugar diet. There are a couple indications where it's first-line treatment, though, which I always found this very fascinating because GLUT1 deficiency syndrome, that's a syndrome where sugar can't get into the brain as well. And so how do you bypass that? Well, the brain doesn't rely on sugar anymore, then it relies on fat. So that's really cool, and that's the idea behind it. So there are a couple times where it could be the first-line treatment for those very specific indications. We might consider it early on in syndromes that we know are unlikely to be fully treated with medications alone, then we'd want to consider it early on. So things like myoclonic atonic epilepsy, which can traditionally, for some people, be quite refractory to medications, Dravet syndrome, Fires is a specific epilepsy secondary to a febrile infection where the hypothesis there is that it's the inflammation, the acute inflammation, has contributed to the seizures, and there's some thought that the ketogenic diet is acting on that inflammation. And then infantile spasms as well. If they're refractory to our first-line treatments for infantile spasms, then want to get started on the diet early. Efficacy is, I often think of it as another medication option, perhaps a really good medication option, but it works for some people, doesn't work for other people, has side effects for some people, and other people tolerate it really well. The other tricky thing about the diet is if it does work well, then long-term, what do you do? Because it's not good to be on a super high-fat, low-protein, low-sugar diet long-term. You have to look at things like lipids and heart disease and bone health. And so that's just another factor to consider when you're weighing your options for dietary therapies. But it can be an extremely effective tool when medications alone hasn't helped to calm down that seizure burden. And then if it works, maybe you do it for a few years and then you would wean off of it, kind of like you would consider for other medications as well. I guess I'll pause there.
So we might have -1 minute, is that right? Okay, in 1 minute, I'm just going to go through a couple things. These have been touched on, but I just want to reiterate them, which is sort of the other things, the less invasive things that we should be thinking about, and a lot of them are well covered in the prior talk. All these things should be done really in parallel, right? If you have a problem you want to solve, you should be using a multi-pronged approach to solve it every possible way. So I don't want these lifestyle things to be abandoned when we start talking about invasive treatments. I am going to do this in 30 seconds. So these sleep things are critical. there's some side notes here, but improved sleep almost always means improved seizures. And I don't want to lose that when we talk about invasive treatments. Treating stress and mood is also very important. I don't mean to say that being stressed or being depressed is why someone has seizures, not at all. But those things don't make anything better. They don't make diabetes better, they don't make hypertension better. I mean, they exacerbate those things, they also exacerbate seizures. So treating those things is really important. Exercise does not improve seizures in our literature, but it does improve quality of life and mood. And then being attentive about triggers is really important and can be highly individualized and highly effective. And there we go. I believe that was a question about EpiMonitor, the seizure detection watch. Oh, EpiMinder? Okay, so this is a moment where we would love for you to teach us. Do we have a microphone to share? So we're not familiar with it, and we would love to become familiar with it. Would you be comfortable telling us about it for a minute or so? Okay.
But just real briefly, just because we also want to get.
Okay, an EpiMinder is like a hearing aid. It goes up over the ear if you thought you were seeing a hearing aid, and then it goes down the back, and then it goes up into the back side of the head. So far, as far as I know, the only country that has approved this is Australia. It has been approved just recently by the FDA, and I got this message from my neurologist.
Thank you so much. So you know more about that than I do, but I wanted to just introduce the broader topic, which is a really important one. So in this new era, we now have a plethora of devices that have been developed that are implantable devices meant for the long term to record EEG activity and to understand in real life, in real time, if people are having seizures. This is one such device which has been started in Australia and I think is starting in clinical trials in the United States. That could hugely transform the way we diagnose and treat epilepsy. Thank you so much for bringing that up.
That's great. Thank you. Dr. Chloe Hill, Dr. Carrie Neville, thank you so much for the energetic and informative presentation. The Q&A has already started, so I appreciate that. We have about 10 minutes for question and answer, so we have some microphones roving around here. Do we have a first question? We have one up front here. Microphone is on its way.
And while that's coming, I'll just add real quick. Briefly looking up, it looks like that is perhaps more seizure detection, which I also think is an important distinction. So it's diagnostic tool, and that's probably why another reason we didn't bring it up in our talk today, because the devices I talked about were therapy tools. So there are a lot of ways that we can improve our detection and understanding of someone's seizure, but you want to understand the difference between a diagnostic tool and a therapy tool.
Regarding the RNS, so you use the verbiage that it can be trained in a way, right, the device. So can the pattern like change and you can retrain it basically? When making the adjustments, you kind of retrain it? Is that what it is? And can you put two devices, not one? If you know a couple of spots, but there's that third one that you're maybe a little, is that a possibility?
That's a great question.
Reasonable?
That's a great question. So the information you're recording, you're recording electrical activity only from that area is another thing to keep in mind, right? So you have a couple electrodes that are covering like several millimeters of brain tissue. And so you're recording the electrical information from that person's brain from that area. And so it's not usually so much that the person's EEG is changing and dramatically, but that you're getting better at detecting it. Like you're recognizing the patterns over time. So the more data that's uploaded, and you can look at more of the seizures that they're having and then the patterns between seizures and then dial down into what are the important patterns to be stimulating on. That's how it kind of changes over time. I think that is one of the goals, is to be able to stimulate perhaps even more than 2 spots. For some people, potentially, yeah.
Good question. We have one more in the front here.
Or is a lower sugar diet also helpful?
Yeah, that is also very patient dependent, I think, too. In my experience, traditionally, when we start the diet, we will set a ketone goal, perhaps of 4 to 6. And some people are able to achieve that and do really well. Some people aren't able to get that high, but their seizures improve. And so then we kind of change our goal based on that person and that person's response and tolerance. And then that's where the modified Atkins diet and the modified keto comes in, is that your goals might be lower and your ratio might be lower, but you could still have benefit.
I would agree with that, and I think it's an excellent question. In the adult population, for whom it's harder to control what people eat, and for whom cardiovascular disease risk becomes a more significant consideration, we'll often turn to these modified diets, and some people experience great benefit with that.
We've got a question over here. Sorry.
Great.
Do you see ablation surgery reducing resection surgery?
That's a very good question. I'm not going to quote numbers to you because I don't have those in my head, but I'll quote what I know. Tell you what I know about it. So in our data to date, we do think that resective seizures are slightly more effective. Resective procedures are slightly more effective at treating seizures, at people achieving seizure freedom, than the ablative seizures to date. Sometimes perhaps the neurocognitive outcomes can be slightly improved in an ablative seizure than a resective seizure, because obviously less tissue is involved in the surgery. So oftentimes we will first do an ablative surgery, and that can be sufficient, and that's fantastic. If unfortunately that's not enough, then we can come back and do the resective surgery. So it's very nice in that it doesn't take it off the table, and it's a much less dramatic and traumatic surgery for a person to have. I will say, I think what's fantastic about our field is there's a lot of developed right now in neurosurgical approaches for treating epilepsy, and it may be very well true that in a couple years we've shifted to less invasive procedures such as ablation if we have ways to get better efficacy with that.
Great. I think we have time for just one more. We've got one over here in the front right.
And I interviewed with them, and it basically shows the RNS device. It's a whole summary. I had a nice 3-hour interview for 3 minutes on Fox 2.
Great.
So it's something to look into, but they also removed 3 parts of my brain. And I was awake during the surgery, and they were talking to me. I had my neocortex, the amygdala, and the hippocampus on the left side of my brain removed. So otherwise, I won't be able to talk to you guys like this.
Wow.
But I used to have 8 to 10 seizures a day, working full time, stress, anxiety, all that fun stuff. And changed it, of course, on and off. And all this was done back in 2011. I had SEEG in 2010.
Wow.
So
that's incredible.
A lot of work that you guys do, surgery-wise, but I've improved 90%.
That's wonderful.
All right. Thank you for sharing that. That is the end of this session. Thank you, Dr. Chloe Hill and Dr. Carrie Neville. We really appreciate it.
Thank you so much for having us. Thanks.
Okay. Before we break for lunch, I want to call out a couple of things. Lunch is an hour and a half long, and the idea there is, yes, to enjoy some healthy and delicious food, but also to network, get to know each other, and also make your way throughout the Health and Resource Fair that is along the border here. Many of you already have, but we have great organizations here in attendance, and we totally encourage you to engage with them. In your packets, you will find an evaluation. It is likely purple. We really encourage you to fill this out. It is your feedback that helps us iterate and make this conference even better year over year. For the teens who are in the audience, just note that your evaluation is a different color than maybe purple, so we can know kind of who our audience is and evaluate feedback from there. If you have any questions about the Epilepsy Foundation of Michigan and what we do together, there is a booth around here and also a check-in desk. Feel free to ask questions. And along those lines, new this year, at 1 o'clock, the president of the foundation, Andrea Schottefer, will host a special session on what is the Epilepsy Foundation of Michigan, what do we do, and how can we connect. And so if you are new to us and we are new to you, I highly encourage you to attend that at 1 o'clock. At 1:20, Andrea Thomas is a psychologist at Henry Ford Health's Comprehensive Epilepsy Center. She will host a mindfulness session, and that's going to be great, and that is sponsored by Henry Ford Health. And so thank you, Henry Ford Health, for that sponsorship. And now lunch. Lunch is served in the back of the room. The Vista Tech team will go around and dismiss each table. Expect a line up front, so it's a great time maybe to connect and see our partners along the walls here while that lunch dies down. But the Vista Tech team will dismiss each table. Thank you.